Campus, the Medical College, Kolkata. I invite you all in this digital platform for having a discussion on a very important topic of the time is the dengue. And we are really blessed and feel honored also. And it's a privilege to have with the official dignitaries with us. We have the Dr. Mr. Narayan Sarup Nigam, IS officer, Principal Secretary, Department of Health and Family Welfare, who is being welcome, sir, in this platform. We have Professor Aniruddha Niyogi, Special Secretary, Department of Health and Family Welfare, and in charge of the Director of Medical Education. So I also a heartfelt welcome to you. And with us, Dr. Siddhartha Niyogi, DHS sir, he's always helpful. Only because of him, he requested me to have another webinar on dengue, because just the span of 3 months time, we are doing the second time. The second week of July, we had another dengue webinar, and it was a very good response also. So sir requested me to do another dengue webinar. So we started this program. And now I request Dr. Sir Nigam Prasad sir to say a few encouraging words for this webinar. So I request you, sir.
First of all, let me thank you and DHS sir both for organizing this today's interaction. You know, dengue is a topic of the day today. In case anything bigger political news or something else is not there, then the dengue always hits the first page of the newspaper. And whenever anyone doesn't find anything, dengue, the death, dengue, baad, ched, dam, ilaka, this all comes. So it's very important for us to understand what is happening. And after all, dengue is a public health issue with us. Though in tropical countries, we will have this kind of problem, but the kind of seriousness it accords, that it always catches the public attention, and involvement of public is also very important to understand the disease. Because it is something like we always assume viral fever is an order of the day, Samanya Kichu cold is an order of the day, conjunctivitis may be an order of the day. But what we can do to how much serious it can be, and how to prevent the catastrophe out of dengue. The dengue is dangerous because the symptoms are so bad. I remember one of my institute junior, he was working in excellent software from way back in 94, 95, 22-year-old boy. All of a sudden he succumbs to dengue. We went with the best of the treatment in Noida. We couldn't save him. He was one of our very dear friends. We were staying together in flats. So once it starts a downhill, the platelet falls, the body starts leaking, it's almost becomes impossible. So how to take care of this situation becomes very important one. Secondly, getting the public know about the problems of the dengue. And third is a change. You know, people don't understand that all kind of jargons that we use, but if we can effectively communicate with the public at large, tell other stakeholders, if you don't do this, results will be catastrophic, then only the public discourse will develop. You know, and seeing this, we do almost 6 months before we start our preparatory step. Maybe the dengue season will end by the December. We will have our first meeting again in the month of February to do the preparatory steps, and the huge whopping budget do we involve. So the intellectually it is very essential for us to understand where the disease is taking place, so that we must plan. Now, my only request to everyone who is present here, since all of you definitely represent a think tank of the medical treatment, please do analyze this disease from an epidemiological perspective, its evolving perspective, and what can be our strategy to deal with the repeat of this disease in the near future, so that next year we don't have to face such a catastrophe. Maybe something like this kind of narrative. And secondly, I will also like to request all of you to have a look at the treatment protocols also, whether there is some need of modifications are there. Third is how to communicate it to your others who are dealing with the dengue, say a GDMOs or remote PSC, then in the different people who open the chambers, say, even your quacks also, if they can be communicated that these are the dangers of the disease. If you do 2, 3, 4, 5 these steps, So it is very essential that we all know where we are heading, what is a way forward to take care of it. Suppose I ask you what should be done to control dengue, we just can't sound clueless, otherwise everyone will become clueless. So once again, my thanks to all of you for coming together, organizing this seminar, and definitely we will have some better clarity at the end of it, better clarity what is to be done to deal with the situation. Thank you.
Thank you, sir, for this encouraging and very informative and crisp message to us. Now we have Professor Aniruddha Niyogi. Has he joined, sir? I can't see him, sir.
No, I don't know. Dr. Niyogi may not be. Dr. Siddharth Niyogi is here.
Okay, sir. Okay,
I am
I
here.
call sir.
think-
Yeah, sir, I can see you.
Requested
Yeah, I
to
can
come
see
also.
Yeah, okay. So, sir, Dr. Siddharth Niyogi, sir, DHS, the Department of Health and Family Welfare, so I request you to say a few words on this occasion. And before that, sir, I request the host, please unmute all. And if anyone has opened in a two devices, please put up, because lots of echoes are coming. Please put up the second device and log in one device and mute all, except who is speaking. Sir, please now start.
Good evening to all. So, Dr. Professor Kalpana Datta came to here for a meeting, I think, with the family welfare. So, I requested him, can we have a workshop on dengue? Anyhow, so she has arranged it, and I thank her for doing this. And I see so many people has joined, and everybody is busy. All patricians are busy. So we want to. Why I asked her to make this program? Actually, we have noticed. I personally also noticed that whenever a child goes to the pediatrician, I'm not everyone, but someone prescribes antibiotics. Even the dengue is positive, we are getting. And someone prescribes 2 antibiotics. I do not know what is the justification. So all these things we have to discuss whether there is, as per our protocol, it is not required. So I know one case, one pediatrician recommended antibiotic, another went to another pediatrician. So the person omitted the antibiotic, but it is not under protocol and it is not required. I thank the person who has done it. I do not want to name the person. Anyhow, this has to be done, and the child is improving now. So this we have to take. So there should be justification of whatever medicine we are giving, and that thing has to be discussed in this webinar, and that should be shared with us so that if any change is required in our protocol, so we can make it. Is not a problem, but we must get the information that we may correct it. So we can again sit and we can do it. So please continue your program. I thank all the pediatricians who have joined this webinar. Thank you.
Thank you, sir, for a nice and kind words. Dr. Mihir, sir, Dr. DMS Aniruddha Niyogi sir has written he is not getting the link. Just take care. Ask Somnath to send the link to Dr. Aniruddha Niyogi.
Okay, I'm sending it.
Okay. So now I request Dr. Dipankar Maji sir. He was there as a joint director, Department of Health and Family Welfare. Is always there with any program when we do.
Visible.
Yes, I can't see because I saw his name, so I know he is there.
We are making him visible. He always remains at the back.
স্যার উনি সবসময় আমাদের পাশে থাকেন সব প্রোগ্রামে রয়েছি আর ওনার প্রেজেন্টেশনটা খুব ইনফরমেটিভ স্যার কিছু বলুন ইনঅগ্রেশন সেশন দেন উইল লিসেন ইওর সেশন ইন দ্য এন্ড ডক্টর মাজি প্লিজ স্যার
Yes, ma'am. It's very relevant to discuss dengue even after this 4-5 months of going through this surge, because as days move on, we see newer and newer presentations of even this old disease. Because nowadays, lots of news are coming to us of cases, dengue cases, suddenly deteriorating due to myocarditis, dengue cases presenting with AES, acute encephalitis, and all that type of different presentations that were not frequently heard earlier. So I think when we discuss about pediatric case management or in any age group, management of dengue, when we discuss, we should take into account these newer presentations of these cases, and some different value additions have to be done in each of this type of programs. Thank you, ma'am, for arranging this.
Ajay, you make introduction to the other person present here.
Oh, so that's an opportunity to introduce the dengue team working over here day and night. So on my left, yes, he is visible on the screen. Dr. Sudipto Bhattacharya, who has joined just a couple of months back. He is a leading person of the dengue data analysis team. And next to him is Dr. Taposh Kumar Roy. He is the SPO for NVBDC. And on my opposite side, Mr. Rupam Banerjee, he is Additional Secretary, PHP, giving all the fund support for the initiatives that we take every year.
Keyboard of Dengue Revisited. Okay, please continue.
Sir, Dr. Oniddu sir joined.
After you go ahead, once he joins, we will.
He will continue once he join. You please
Okay,
continue.
no, he has not joined yet. Okay. So now we
Please
have,
continue.
yes, sir. We have with us our scientific chairperson of West Bengal Academy of Pediatrics, Dr. Swapun Roy, and other dignitaries and faculties. I welcome you all, and you have heard our official dignitaries and some encouraging words and all. And now we'll start our scientific session. I'll hand over this mic to the our scientific chairperson, Dr. Swapun Roy. Dr. Swapun, please.
Thank you, Professor Datta, and thank you all the luminaries on the dais. Actually, it is our second endeavor on behalf of Indian Academy of Pediatrics, West Bengal Academy of Pediatrics. And today we'll start the session with a talk with the Professor Bhashwati Bandyopadhyay. She will speak on the different aspects of the virus and all that. So over to, without wasting any time, I will request Dr. Bhashwati Bandyopadhyay to start her session. Are you there? Yeah.
Yes, sir. I'm
Please,
here.
please continue.
Good evening, everybody. Respected dignitaries, Principal Secretary, sir, DHS, sir, Professor Kalpana, madam, respected Chairperson, sir, and all other dignitaries. I'm really thankful for giving me this opportunity once again. And I hope to address some of the issues that have been raised. Am I audible, sir?
Yes, you are.
You are visible.
Yes, you are. Come on, let's go.
Please continue.
My intelligence.
Okay. So the screen is audible also, right?
Yes, yes, okay, please
Visible.
continue.
Okay. Thank you, sir. So, as we all know that dengue fever is an acute infectious disease that occurs mainly in tropical and subtropical areas and is one of the most severe mosquito-borne viral diseases in terms of human morbidity and mortality. The spectrum of dengue virus infection spans the range from asymptomatic infection to clinically apparent disease and resulting even to severe disease and may result in death. It is estimated that around 3.6 billion people, that is more than half of the world's population, live in areas that are at risk for dengue virus infection. And the WHO estimates that nearly 50 to 100 million infections occur each year, where some estimates have shown that almost 400 million infections, up to 400 million infections may also occur. Now, this is the dengue virus, which belongs to the genus Flavivirus, under the family Flaviviridae. Now, this is a small virus, around 50 microns in diameter, 50, and it is spherical in shape, 50 nanometers, sorry. And unlike we have always been familiar with the picture of coronavirus, where the envelope proteins have a spiky appearance. Here, it is a rather a smooth appearance, like a golf ball, as the envelope proteins they lie flat on the surface of the envelope. So this is the characteristic of the flavivirus. Now, what are the important flaviviruses that occur in that are there? So, dengue virus is one of them, Japanese encephalitis virus, West Nile virus, yellow fever virus, and the recently emerged Zika virus. Among these, dengue, JE, and West Nile are common in India, and West Bengal, dengue and JE. We haven't seen a case of Zika virus. Now, just 1 minute. So, among these viruses, dengue and Zika, they cause febrile illnesses, whereas JE and West Nile, they cause encephalitis. Now, this is the schematic diagram of the dengue virus, and inside is the viral genome. It is a single-stranded positive sense RNA, and it is enclosed within the capsid protein, and this is covered by the outer envelope, and from which the envelope, the glycoproteins like E protein and M protein are present on the surface. Now, this is the genome of the flavivirus genome, which is approximately a RNA virus. So it is approximately 11 kilobytes in length and is composed of 3 structural protein genes that encode the nucleocapsid or the capsid protein, the membrane-associated protein, and envelope protein, and 7 non-structural genes. And these non-structural proteins are assumed to be involved in viral replication and viral assembly. Now, dengue serotypes. There are 4 dengue serotypes, 1, 2, 3, and 4, with around 30% difference in their overall amino acid sequence. Each serotype is capable of causing the full spectrum of clinical disease. A 5th variant has been reported, but it is not reported in India. It has been shown to be circulating in non-human primates in the forests of Southeast Asia and with occasional spillover into humans, but not reported in India. Although all the 4 serotypes are antigenically similar, they are different enough to elicit cross protection for only a few months after infection by any one of them. And the immunity to the homologous serotype is lifelong, but it is not a long-lasting, does not afford long-lasting protection to the infections caused by the other serotypes, which are not the ones that is infecting the person. Now, dengue genotypes. This is also important. So there exists, so now as we have seen in the coronavirus, we have seen that there were so many genetic variants, the Delta variant, the Omicron variant. Some were mild in nature and some were very virulent. So also in the dengue virus serotypes, each serotype has number of genotypes or variants, genetic variants, some of which are quite virulent, particularly the Asian variants, and some of them are mild, the American variants. Now, with this brief background, I move on to the laboratory diagnosis. Now, let us see the timeline of the biomarkers that happen in a dengue infected patient. So here you can see that from day 1 onwards to day 5, there is a viremia, and during this time, this is the ideal time for doing, if you want to do virus culture, this is the ideal time for collection of the sample, and also if you want to do the molecular test like the serotypes, this is also the ideal time of sample collection. NS1 antigen also becomes detectable on the first day of infection, and it can be there. Some studies have reported up to 9 days. The IgM appears after the 4th day or 5th day onwards, and it is there for some time, persists for some time. Now coming to the IgG. So if it is a primary dengue infection, the IgG usually appears at the end of the first week, that is 7th day onwards. And if it is a secondary dengue, then the IgM may have an earlier onset, maybe as early as 3 to 4 days of infection. On the right side of the picture, we can see the timelines again, but why have I included these two pictures is that there is a difference in the peaks of the virus and the NS1 antigen levels. In secondary infection, the peak is rather higher, that is, there is more viremia, but the time is shorter. So it is a short transient viremia, or maybe due to the formation of immune complexes, these detection window of the NS1 and the virus becomes less. Whereas in the primary infection, the detection window of both the virus and or virological markers as well as the NS1 antigen is much more than in secondary infection. So this is important that in secondary infection, if the timing is not correct, there may be a window where the serological tests may be negative, which I will talk about later on. Now, the tests available are, as we know, virus isolation, mainly of academic and epidemiological purposes required for serotypic or genotypic characterization, viral nucleic acid detection, that is for which we can do by RT-PCR test, viral antigen detection or NS1 antigen test, and immunological responses like IgM and IgG antibody tests, and also the hematological parameters, which my clinical counterparts will discuss more in details. So this is the comparative merits and of the direct and the indirect laboratory methods for the diagnosis of dengue infections. On the left side of the picture, you can see that virus isolation, genome detection, and antigen detection, and NS1 antigen detection, these are more direct methods of detection of the virus, and the specificity is much higher than the indirect methods. So if these tests are positive, we can say by confirmation that this is a dengue infected case. On the other hand, the indirect markers, that is the IgM and the IgG, they have less specificity, but the opportunity for testing the serological markers is much more than the virological methods. So this is the merits. And now coming to the serological tests, currently the most widely applicable methods in routine diagnosis are NS1 antigen, IgM capture immunosorbent, that is MAC ELISA, IgG ELISA. Rapid tests are not recommended, and hemagglutination inhibition tests are more of academic and research purposes. Now, NS1 antigen. So the NS1 antigen gene product is a glycoprotein which is produced by all the flaviviruses and is essential for replication and viability of the virus. It appears as early as day 1 and after the onset of fever, and it can be seen quite a long time if it is a primary infection. Present in high concentrations in the sera of the dengue virus patient and can be detected in both patients with primary and secondary infections for up to 6 days. Commercial kits for NS1 antigen detection are not available. They do not differentiate between the serotypes, but they can be used as an early diagnostic marker for clinical management. Now, what are the advantages of NS1 antigen? Detection of an NS1 antigen is perhaps the most robust of all the dengue virus diagnostic methods, with a relatively long detection window, particularly in primary infections. NS1 can be detected at the same time as viral RNA and before an antibody response is mounted in primary infections. It can be viewed as a surrogate marker for viremia. Then the commercial development of NS1 as a diagnostic tool has revolutionized dengue diagnosis, as it has provided a very simple and low technology assay and that has high sensitivity and specificity. Commercial dengue NS1 antigen capture ELISAs have been designed to be highly specific with no demonstrable cross-reactivity with other flavivirus NS1 species. Now, what are the limitations? So, NS1 detection may be obscured by immune complex formation for patients experiencing a secondary infection, thereby narrowing the window of detection. This is possibly due to the rapid anamnestic rise in NS1 cross-reacting antibodies during the acute phase of the disease, and possible cross-reactivity detected in a recent Zika virus infected patient. So the specificity of these assays need to be revisited in areas where Zika virus infection is also occurring in the background of dengue viral infections. MAC ELISA or IgM capture ELISA. This is usually detectable by 5 days of illness. The time of appearance of IgM antibodies varies considerably among patients, and IgM antibody titers in primary infections are significantly higher than in secondary infections. And in primary infections, the IgM may persist for 60 to 90 days, and MAC ELISA positive results on single serum samples are only provisional diagnosis and do not necessarily mean that the dengue infection is a current one. IgG ELISA can be used to differentiate primary and secondary dengue infections. It is simple and easy to perform, but it is very non-specific and exhibits broad cross-reactivity among flaviviruses, particularly JE virus and other flaviviruses that are circulating in the area. It cannot be used to identify the infecting serotypes, and these tests can be used independently or in combination, depending upon the type of the sample and test available to confirm the diagnosis. Now, IgM-IgG ratio, again, so greater than 1.2 or 1.4 is the one that has been accepted, but now there has been, it has been revised by some laboratories. So it depends on their in-house performances. Now, RT-PCR test for dengue virus detection not required as a diagnosis for clinicians, but sometimes it may help as an adjunct to diagnose. I'll show some cases I'll discuss where we can see how it has helped. So better specificity and sensitivity compared with virus isolation with a much more rapid turnaround time. Usually, RNA detection levels are reduced after the formation of antibodies. It can detect the 4 serotypes of dengue virus, more advantageous in respect of rapidity, quantitative, lower rate of contamination, and high specificity and sensitivity. But the disadvantage is that sophisticated equipment and skilled personnel are required to carry out this test. Now, all serological tests are prone to false positive and false negative errors. So the sensitivity and specificity of IgM-based assays is strongly influenced by the quality of the antigen used and can vary greatly between commercially available products. Many ELISAs use dengue E protein antigens from all the 4 dengue virus serotypes, and this ensures that the assay is capable of identifying any dengue infection regardless of the serotype. In general, 10% false negative and 1.7% false positive reactions have been observed. Now, coming to the interpretation of dengue diagnostics. So, if we have only IgM positive in a single serum sample, that can be used as highly presumptive or highly suggestive. Or if we have a IgG positive serum, if we can do the HI titer more than 1280, then that is also a highly suggestive of dengue, but not confirmed. When can we say that it is confirmed dengue? When it is RT-PCR positive or culture positive, or there is IgM seroconversion in 2 different sera. IgG or IgG seroconversion in paired sera, or 4-fold rise in anti-IgG increase in IgG titer in paired sera. So this is almost the similar diagram like that, but here it omits the HI titer, which is not done nowadays. So if we have only single IgG positive, that means past flavivirus infection. Otherwise, if we have a RT-PCR positive or NS1 positive or IgM seroconversion, it means acute dengue, lab confirmed. But if we have only IgM in a single sample, then it is presumptive dengue. And if this acute dengue also has IgG, then probable secondary dengue. And if it does not have IgG, then probable primary dengue. So classification based on serological markers, if it is only NS1 positive and IgM and IgG not negative, then it is early primary. If late primary is IgM and IgM positive and IgG may be plus minus. If it is a secondary infection, so early secondary, then NS1 along with IgG and some amount of IgM may be there in low titers, and in a late secondary, both IgM and IgG may be positive. Now, sample collection is 3 to 5 ml of venous blood, appropriate labeling, and to be transported in cold chain if molecular tests are to be done, and if only serology, then it should be transported in ambient temperature. National Vector-Borne Disease Control Program recommends only ELISA-based NS1 antigen detection test and IgM capture ELISA. Now, given the varying kinetics of each biomarker, no single assay can be used to definitively diagnose den virus infections in patients who may present at a different stage in their infection. So this is, in one outbreak situation where we had collected samples from 4 patients, and the first 3 patients had very much suggestive of dengue. They were very strong suspicion of dengue, and the 4th one, it was not at all a dengue suspect. But when there is an outbreak, all sorts of people with fever, they come and attend. Now, this second patient, you can see that it is negative for NS1, IgM, IgG, chikungunya, scrub typhus, and leptospira, everything. So now what we did is we did the molecular test. So because NS1 was not positive in an early sample, then I thought maybe we are dealing with chikungunya or Zika. And so we did this serotyping, and we can see that the serotypes were all detected. And in the same epidemiological setting, it is the same serotype which is detected. The 4th patient was absolutely negative for everything. This is another a 15-year-old girl, just presented just in the last quarter of this month for 6 days with maculopapular rash and platelet count of 130,000. No tropical fever test was done up to for day 5. Dengue IgM and dengue NS1 non-reactive. Suspicion of dengue was there. And on 8th day, dengue IgM was reactive. So sometimes if there is a strong suspicion, we have to repeat the test, and maybe we can do the molecular test. So this patient did not have the access to molecular testing. Another patient, 48-year-old man, presented with 5 days fever and rash, a strong suspicion of dengue. For confirmation, NS1 and IgM was sent. Both were negative. And because now strong suspicion, dengue PCR was done and serotype 2 was detected. So sometimes molecular testing may help as an adjunct for early diagnosis. This is one of my data from one of my students who has done the thesis this year. So recovery and mortality rate of primary versus dengue infection. So actually primary dengue deaths can also occur, although the death rate is higher in secondary infections. But the better side of this slide is that 99% of the primary infections can, there is absolutely no mortality, whereas even 95% of the secondary infections have no mortality. So this is the brighter side. And the treatment, if facility availed by the primary versus dengue, yes, the primary patients were treated more in OPD basis and the ward, whereas hospitalization was more in secondary infection and ICU admission was more in secondary infection. But nonetheless, primary infections were also admitted to ICU. So apart from immunological responses, maybe there are viral intrinsic viral factors which may also be responsible, or there may be genotypes which may be responsible for severity of the infection. Now, this is the serotypes which have been seen from, this is some of my previous data. In 2017, we can see that there was more dengue 2 compared to dengue 3 and dengue 1.
Sorry to
And
disturb you,
in,
madam. You have 2 minutes more. Okay, 2 to 3 minutes.
I'll finish. Yes, I'm almost done. And from 2021, you can see that the predominant serotype was dengue virus 3. And in 2022, some amount of dengue virus 2 started increasing. In early part of 2023, there was dengue virus 3, but now in the later part of this dengue season, it is dengue virus 2 is also catching up. Now, why I am telling this, has some epidemiological importance. And a very beautifully described paper, meta-analysis of dengue severity during dengue infection. So all of you can read this paper, and it has said that dengue 2 and dengue 3, dengue 2, 3, and 4, they can cause more secondary infections. So if your patients have had a recent dengue in the last 1 year or recently, please tell them to be more careful, because dengue 2 and dengue 4 are now coming into the circulation. So this is one important message which can be inferred from this study. Maybe many of you are looking for a dengue vaccine. Yes, live attenuated dengue tetravalent vaccine has been approved by the European Union, but I don't think it is still available in India, and it can be given to dengue naive patients. And thank you all for your patient hearing. I'll be happy to take up questions if there is any.
Professor Bandyopadhyay, for your elaborate presentation. I can see few of the questions already you have answered.
Okay, let me stop sharing the screen, and then maybe I'll
Me?
see that.
Yes.
Yeah.
So,
Can you take up the questions?
yeah. There's one question from Dr. Bholanath I. Just should we ask for both NS1 and IgM on the 3rd to 5th day of fever?
You can ask. You can ask, but you can ask definitely. But if you don't get it, you have to repeat the test.
Sure. And another question, logistic
Where
point.
is dengue PCR done? Yes,
PCR
dengue
done.
PCR is done in many laboratories in the government setup now. So Dr. Dipankar Majhi, I think sir will discuss that issue in details. In many medical colleges have started doing dengue PCR. Funds have been given.
Okay. So there are no more questions in the chat box. I think if there is further question, madam, you can stay here for a few more minutes and you can answer. Okay.
Yes, I will answer in the chat box. I think last time there were many questions which I have addressed this time.
You
Hello.
have already addressed all these questions.
Sunday ki tomar admission chilo ei Sunday?
Madam, Kalpana madam, please mute yourself.
Oh, একটা বাচ্চা ভর্তি হয়েছে
Meet, please continue.
Yes, so moving to the next session, so there is a few change in the schedule from the last time. So next will be the panel discussion on the day-to-day management of the dengue patient in our OPD, or the patient are admitted in ward but not so severe, just with a few warning signs. To discuss on that, the moderator of this session is Professor Sunita Basu from the Vivekananda Institute of Medical Science, Kolkata. And the panelists are Dr. Amita Sinha, Dr. Sharbani Mishra, Dr. Bholanath Aich, and Dr. Nilanjan Ghosh. So over to Madam Professor Dr. Sunita Basu to introduce your panelists and start discussion.
Okay, good evening, everybody, and thank you for this opportunity. I hope I'm audible as well as my slides are visible.
Yes, ma'am. Please go to, yes, go ahead.
Okay. So thank you again, and my welcome to my panelists, Dr. Amita Sinha, Dr. Sharbani Misro, Dr. Bholanath Aich, and Dr. Nilanjan Ghosh. So straightway going into a case. The first case was a 5-year-old boy who came to the OPD with a history of fever for 4 days along with headache. He vomited several times and his intake was poor, but he did not have any other complaint. On examination, his weight is 30 kg with a BMI falling in the obese percentile. He is febrile to touch. His peripheries are warm. His face is flushed. Pulse is 100 per minute, but the dehydration was not there. With BP of 90/60, his throat was normal, systems were normal, and there were no meningeal signs. So this is a very common scenario that we are facing nowadays. So my question would be to Dr. Sinha, what is your provisional diagnosis in this case and what will you do for this child?
So this is a case of fever for 4 days with vomitings, and this is an obese child. So we have to, in this season with a epidemiological preponderance of dengue, we have to keep this case as a suspected dengue also. And since this child is vomiting several times, his intake is poor and he is obese with a flushed face and a BP on the lower side, we would prefer to get him admitted and further manage. And if not, at least we have to get the child investigated and investigated for CBC, NS1 antigen, dengue, and malarial antigen. And then tell him about the warning signs because he is obese. And if the child gets admitted, well and good, then paracetamol, IV, oral fluids or IV fluids as per requirement, and other supportive medications. But keeping in mind that the child is obese and he has a flushed face and a lower BP, preferable to warn him and keep him under monitoring. And at least if he's not getting admitted, to tell him about the warning signs or tell him about the signs which may put him at risk for further complications.
Yes, thank you, Dr. Sinha. Yes, very well put. What is important is in a very busy OPD when we have so many patients flooded with the similar complaints, we have to remember that there are these indications for admission, which is very clear. And we just heard that, very often these children suddenly deteriorate. And if they're staying far away, if their mother is not very comfortable looking after this child at home, like you said, there are comorbidities like obese. Yes, it's very important that we need to admit this child. So my question next is to Dr. Aich. What would be the differential diagnosis? Because, we have fevers with no focus nowadays, and they're coming with multiple, loose motion, cough. Like this particular season, we are having so many of these other viral infections. So we need to have a differential diagnosis. What would they be, Dr. Aich?
Yes, ma'am. Thank you. The first of all is in this period of time with the epidemiological profile which is going on nowadays, I'd like to keep in my first diagnosis, in differential diagnosis, all the tropical fevers. These are the fevers which are more than 38 degrees centigrade. They're lasting for more than 48 days, 48 hours. And I just like to keep dengue as my first differential diagnosis in this case. Malaria, scrap typhus, enteric fever. These are very common tropical diseases, and they are very highly epidemiological and has a very high endemic profile in our areas. Leptospirosis, that was an old disease and still making some bad condition in the child. And then this scenario of the child who is vomiting may be a very early sign of an acute encephalitis, although we don't have any meningeal sign right now. This could be a very early sign for an acute viral hepatitis, although we should wait and see what it does. But other than that, ma'am, I should, with the scenario which is going on right now, influenza, the flu-like illnesses, that can also come with a very similar profile with a 4 days fever. But I just also have to keep in mind that this is a child with many comorbidities, and although also it's showing low BP and some other clinical features which also needs that the child needs more attention, and so to be managed accordingly.
Thank you, Dr. Aich. So how do we define tropical fevers, Dr. Ghosh?
Yeah. Am I audible? Okay, fine. Well, the term is quite self-explanatory. Tropical diseases. These are the diseases that we find in the tropics and subtropics areas over a particular period of time. And as per definition in 2021, these are defined as The criteria are that fever that will be lasting at least 48 hours and duration of onset with less than 14 days. There won't be any localizing signs like pneumonia, bronchiolitis or UTI or soft tissue abscess or infections. Clinical and laboratory evidences of one or more organ system involvement like the hematological system or the circulatory system, etc. Desirable criteria are one or more systemic features such as edema, hepatomegaly, and or splenomegaly, encephalopathy. And there is sometimes a seasonal trait, although it may not be there. These are the definite criteria for tropical fevers. Yeah, this is the definition.
Okay, thank you, Dr. Ghosh and Dr. Mishra. Now this patient has come to you. What will be, in general, what was the outpatient management of a suspected case of dengue?
Good evening. Am I audible?
Yes.
Okay. Then while treating the patient at OPD basis, we have to thoroughly taking the history and do physical examination and to assess the disease severity. So 3 golden questions to be asked about the sensorium, whether the patient is active, alert and cooperative, about the water intake, whether patient is able to drink and can retain it and not having any abdominal pain or vomiting, and passing urine at least 4 to 6 times per day, and having no warning sign or any organ damage or comorbidity or bleeding manifestations. And these patients can treat at OPD. And of course, the date of fever. Usually the fever lasts for 2 to 7 days and critical phase comes after 72 hours. So date of onset of fever is also very important.
Yes. And you definitely want to explain to the mother about what to do about the fever control.
Warning signs to be explained properly about the warning signs. And there are some social indication also if the patient is staying alone and away from healthcare facility and having no travel facility, and staying alone, and there is no one to look after. So we have to admit those patients, and you have to explain the warning signs like vomiting or diarrhea or perspiration or diminished urination. And at that time, we have to tell the patient to bring back the patient immediately to the hospital to get admitted.
Yes, and the important is that nowadays there are so many different types of analgesic and combination drugs which our parents are using. We have to strictly tell them, please do not give any ibuprofen or aspirin containing drugs, mefenic acid. The paracetamol is safest, and the correct dose and the correct duration. And also look for the warning signs like you said, and come back to for a recall as early as possible, if necessary the next day when the suspicion is very high. So what are the criteria for admissions in a suspected case of dengue, Dr. Mishra?
If there is persistent high grade of temperature and the patient is having vomiting and not able to take retain the water, and also the having risk factor like intensive obesity, pregnancy, hypertension, or previous organ damage like COPD, renal disease, hemoglobinopathy, and patient is having some medication like corticosteroid or immunosuppressant or anticoagulant, and that warning signs are to be also looked at. So any comorbidity, risk factor, and any organ damage or severity like bleeding or hypotension, perspiration, these are the criteria. These are the moderate dengue. These are to be admitted.
Yes, and also very young children, especially when they're not taking adequate oral feeds, it's always better to admit them. So this child we've admitted, since you said he was an obese child and he was vomiting, his intake was poor, so he fulfilled those criteria for admission. So we admitted this child and we did an initial CBC which hemoglobin of 14 grams, the low total count of 3,100 and platelet of 90,000. And his NS1 came positive with his electrolytes were normal because he was vomiting. So we did that and that came normal. Now, we will not go into the question of sensitivity, specificity of NS1 because we just heard a detailed discussion of this. I would like to ask Dr. Aich, would you prefer to send PT? We know we send CBC, CRP, electrolytes on most of these cases, but would you want to also do a PT, APTT, LFT, and why? Dr. Aich?
Yes, ma'am. I should go for a PT, APDT, and LFT. The child is already showing some features of hematological system involvement. His platelet is already 90,000, which is low. WBC is 3,100. This child has a chance of developing complications. So that could be a hematological complication. That could be which is affecting the coagulation system. This could be affecting the liver with early onset hepatitis. In that case, we just have to find out those early warning signs. In that cases, the PT, APDT, LFT is a must for this child. So that we can get early, because already the child is showing some sort of affection of the hematological system with the WBC and platelet count going down.
So yes, so important is that we know that very often these children suddenly deteriorate in the next 12 to 24 hours. So we want to keep all those prognostic markers in our hand. We just heard in the initial inauguration that even one child we're losing to dengue is unacceptable. So how do we pick up these warning signs, admit them, monitor them, and then pick up? An LFT will give us some clues. Like, you know, some of the studies have shown that low albumin, raised AST, low platelets, these are all poor prognostic markers. So we can monitor these children much more easily and realize that these are the children who may go into severe dengue. So yes, we need to do this investigation. So he was started on IV fluids because, you know, he was vomiting, he was not taking oral feed. So this along with paracetamol and ORS, which is the standard protocol. Now, what would be the weight would you like to take? Like we always say 3 ml per kg, 1.5 ml per kg. So here his weight is 30 kg. So would you like to take that as or his ideal weight, Dr. Ghosh? And what would be the ideal fluid that you would like to give this child?
Yeah, actually, when we calculate the fluid amount, we take into account the body weight of the child. But here the child is obese, but we won't consider his body weight as he's obese. We should consider always the ideal body weight for that age and that sex. And the type of fluid is that we should be giving always IV fluid should be isotonic, like the normal Ringer's lactate solution or the normal saline. And if it is on maintenance fluid, or we can give along with it 5% dextrose solution along with it. And the formula, we have the good old Holiday Segar's formula to calculate the amount of fluid that is required. I won't go into detail of this because we all of us know this formula. And with patients with warning signs like pain, abdomen, and lethargy with no vomiting or loose motion, we should not give full fluid, but at least 70% of the maintenance fluid. And where there is fluid loss, we should always give the full maintenance fluid. Plus, we should consider the deficit that the fluid loss that has taken place. And patient with evidence of capillary leak that is showing rising in the PCV, 10% from the baseline, 3 to 5 ml of kg per hour fluid should be started in these patients.
Yes, this Holiday Segar formula is as old as 1957. So that was actually originally given for children with a normal activity, physical activity, the basal metabolic rate, and that's how it was calculated. Now, when a child is admitted to the hospital, you know that these children are bedridden, so their physical activity is less. So this formula actually tends to over hydrate these children. And in an obese child, definitely most of these dengue patients, when we follow this method, this particular formula, we overhydrate. So like you said, yes, if there is no fluid loss, 70% of maintenance like 1.5 ml per kg per hour is adequate. But what is important is monitoring. We don't give a direction in the morning and then go and see the child in the evening. Every 2 hours, we need to monitor and see what the PCV like, what are the sensorium like, what has been an intake, has the loose motion increased. So accordingly, we need to keep changing the direction for the fluids. Like we know that WHO protocol for fluid for dengue management is all about fluids. So standing by the side of the child, monitoring him, looking at his blood pressure, and then keeping on changing the direction depending on the situation is very important. And of course, PCV will guide us in that. So question to Dr. Sinha, how do we classify dengue and what is its significance? Dr. Sinha? Dr.
So
Amita Sinha, yeah.
Yeah, so we classify dengue now. It is usually mild, moderate, and severe. But more importantly, we classify as with warning signs or without warning signs. And in the mild variety, they are usually the fever without complications like bleeding or any hypotension or any other organ involvement like the liver, kidney, etc. And without any capillary leak. And usually these patients can be managed at home. Usually they can be managed at home with the warning signs explained. In a moderate dengue or dengue with comorbidities, usually these are the ones with warning signs, and these are the infants, the obese patients, the patients with congenital heart disease, or any immunocompromised patients on steroids, anticoagulants, or immunosuppressants, and these are preferably hospitalized. These patients should be preferably hospitalized. And also moderate dengue are can be classified as ones with warning signs, and these warning signs are usually in the like after day 4, day 5 of illness, and usually these are in the form of recurrent vomiting, abdominal pain, tenderness, generalized restlessness, lethargy, and it can be some form of bleeding like gum bleeding, etc., and mild pleural effusion or ascites, and increased hematocrits and falling platelets. And these need close monitoring in the hospital. And severe dengue, all of us know that dengue with significant plasma leak, with significant hemorrhage, without shock, with dengue shock syndrome, without hemorrhage, and other severe organ involvement like the abdominal compartment syndrome and the dengue syndromes, and also metabolites and electrolytes abnormalities, and these should be preferably managed in a PICU.
Okay, thank you, Dr. Sinha. So what are the monitoring parameters in managing a dengue patient in ward, Dr. Mishra? Can you go through the slide, please?
We have to monitor clinical parameters as well as laboratory parameters. So clinically, you have to assess the intake output chart every time, how much the patient is taking or feeds either in the form of drip or oral, and how much the urine volume is, and activities where sensorium and activity is very important, whether it is interactive, alert, and can retain the fluid. And if there is no bleeding, then you have to perform tourniquet test to assess any bleeding tendency. And sensorium is very important, as I already told, and vital to be taken preferably 4 hourly. Liver size and every ascites or pleural effusion, even if analysis are not fully every time. And in top of this, laboratory parameters should be done at least twice a day, and WBC count, PCB count, and platelet count. Firstly, WBC count tends to fall. Thereafter, the platelets and count starts falling and PCB starts increasing. So, falling of WBC count is also very important, and that signifies patient is entering into critical phase, and hematocrit will start rising or PCB platelet will fall. So, clinical and laboratory parameter both are to be monitored.
So yes, so this is what we are all familiar with, this particular the etopathogenesis of really dengue going into from mild dengue to severe dengue, and this is a critical phase where we really need to monitor, like you said, because here when all the plasma leakage will happen and PCB will go up, so we need to give more fluids. Whereas towards the recovery phase, the fluid will come back into the intravascular compartment, and that is when we have to reduce our fluids. That's very important. So yes, Dr. Mishra again, when did you suspect a case of secondary HLH in a case of dengue in the ward?
Usually dengue fever lasts for 2 to 7 days. So if the fever is persisting and high grade even after 7 days, then you have to think some underlying problem. It may be due to some co-infection like malaria or acute viral hepatitis or leptospira. And after ruling out all the secondary underlying infection, we have to, and if the patient is toxic and deteriorating, and there is progressive cytopenia, hepatosplenomegaly, and most importantly, ferritin has started increasing, and also triglycerides had started increasing with raised AST. So this signifies the patient has started developing HLH. And HLH score is very important. If it is 169 or more, that is significant for developing, signifies the HLH is developing in this patient.
So yes, so this is what we have to keep our mind. These are the children who really become. So initially, if we have a baseline LFT, and then when we see the child is still having fever beyond 4 days, 5 days, we have to look at secondary infection and also rule out secondary HLH, which has a standard protocol for treatment, and we can salvage these children. But we have to keep this in mind. So next, what would be the protocol for fluid management in a child with warning signs, Dr. Ghosh?
Well, first, we must know the warning signs in case of dengue. Let's just recapitulate. It is severe abdominal pain, or there should be tenderness, abdominal tenderness, persistent vomiting, mucosal bleeds, liver enlargement may be there more than 2 centimeters, clinical fluid accumulation may be there, lethargy or restlessness, and most important, increase in hematocrit. We should know all these danger signs. Well, if a patient comes with danger warning signs, then we should always first obtain the baseline CBC, and we should monitor the fluid and fluid intake and output, and also encourage fluid intake, and also monitor the vitals very carefully. As madam said previously, we should not just give the advice and go away. The main thing is look after the patient very cautiously, timely. If the patient is taking oral feeds, well and good, just monitor. But if not, if there is vomiting, then we should immediately start IV fluid, like as I said before, isotonic crystalloid like normal saline or ringal lactate should be started, and the hematocrit should be checked. Stepwise manner this should be given. We should not jump. We should go step by step, very little amount, like 3 to 5 ml per kg per hour for 1 to 2 hours. And we should monitor the vitals again, like the pulse volume, the BP and all this. If there is no improvement, then we go to the next step and keep on going on increasing until the patient is stabilized. And then if the patient is taking oral feeds well, then well and good, we can put the patient on oral feeds. But we should monitor the hematocrit regularly, and the clinical signs like pulse volume, pulse rate, and BP. If it is not stable, we can increase fluid up to 7 to 10 ml per kg per hour for 1 to 2 hours. Recheck again, improvement, fine, we can go back and reduce the fluid level. But if it keeps on, if the patient is not still stable, we should go to the management dengue syndrome. And if the patient is again improving, we should decrease the fluid in stepwise manner, like we increase. This is mainly the fluid management in patients with danger signs.
Thank you, Dr. Ghosh. My next question is to Dr. Sinha. What are the criteria for discharge?
So criteria is when the child is taking orally, when the child is not is stable, is passing adequate urine, and the platelets are more than 1 lakh, and the hematocrit has now normalized. There are no further warning signs, no bleeding, and it's already 1 week into the illness. So these are the criteria for discharge, and we should actually try to discharge the stable patients, because there are many who may just need admissions, and beds are also in a crisis state.
Yes, very well said, Dr. Sinha. So I'll go to my next case. This is a 7-month-old child, infant actually, has been admitted in the emergency with a history of fever for 5 days. She's lethargic, not feeding well. And the NS1 done outside was positive. On examination, he was cold extremities, pulse is feeble, with a systolic blood pressure of 70 millimeter mercury. But there's no signs of bleeding, and the system examinations are normal. So, Dr. Sinha, again, where will you admit? Obviously, this child needs admission. He's an infant, not feeding well, pulse is feeble. So, where will you admit? In the ward or in the PICU?
So ideally in the PICU, ma'am, because this is an infant, and he has most of the warning signs like low BP, and he's not feeding well. So would require intensive monitoring.
And what is the cutoff for acceptable? I think all of us should keep this in mind. Just 1 level of systolic blood pressure is good enough for in an emergency basis to understand how bad the child is. So this is can you just go through this?
Yeah, so in a newborn, it is the lowest acceptable is around 60 millimeters. From 1 year to 1 month to 1 year, it is 70. After 1 year till 10 years, it is 70 plus 2 into age, and more than 10 years, it is 90, the lowest acceptable BP. And mean arterial pressure is 1.5 into age plus 55.
So we have to keep this in mind, because we know compensated shock and decompensated. As soon as the blood pressure falls, we need more aggressive treatment. So thank you again. Now, Dr. Mishra, can you tell us why is dengue in infants an increased risk, and what are the common clinical features in them?
It is due to the passage of maternal antibody from mother to fetus. So this antibody may have some protective role during first few months. So even if the patient is getting a primary infection, NS1 may not be positive due to presence of maternal antibody, and infection can be prevented. But with the time and with decreasing this antibody level, and especially between the age of 4 to 9 months, these babies are especially vulnerable. The persistent IgG antibody that will act as enhancing antibody. So even if primary infection in these infants, they will behave as a severe dengue with dengue 6 DSS or dengue hemorrhagic fever. So 4 to 9 months is the critical age, but the severe form will be happen. And if after 9 months, with further decrease in antibody, then the patient will be manifest as simple dengue fever or omnipresent fever. So 4 to 9 months, this is the criteria, the window period that the baby is mostly affected in severe form.
Yes. So, like secondary dengue, we are all, aware that secondary dengue patients, if they had dengue earlier, we know we need to monitor these children more carefully. So similarly here, the infants also may behave like the secondary dengue. So and of course, they may come with varied manifestation. They may not behave like a typical dengue phase. They become with a running nose, with a cough, with a vomiting, loose motion, multi-system involvement, and there's they quickly become bad. Yes. So the tourniquet test, monitoring them much more carefully, the amount of fluid that we need to give them is extremely important, that we need to admit these children. So this is what we have been saying so far about the secondary dengue. So I'll just skip this slide. Now, Dr. Ghosh, how does hematocrit really guide us in fluid management? Dr. Ghosh?
Yeah. As we have said that before, the main thing is the fluid management in dengue patients, and we should be guided by the hematocrit. So let's have a look at how much fluid to give first, then I'll come to the value of hematocrit. So if we should always have a baseline, we should try to get a baseline value of hematocrit. If it rises by 5 to 10%, then the rate of IV fluid in children should be 1.5 to 3 ml per kg per hour. If it rises by 10 to 20% from the baseline, then it should be increased to 3 to 5 ml per kg per hour. And if it is greater than 20%, from the baseline, the fluid should be increased to 7 to 10 ml per kg per hour. However, what we should remember, it's not the hematocrit, but the driving force should be always the clinical examination, right? Like if the hematocrit is persistently rising and the vitals are unstable, like there is low blood pressure, low pulse volume, there is tachycardia, then we should understand that there is active plasma leakage, and we should give more fluid to the patient. The fluid replacement is required. However, if the hematocrit is rising but the vitals are stable, then we should remember that we do not need any extra intravenous fluid, but we should continuously monitor the patient, and we should remember the hematocrit should fall down in the next in a day or two. So we can do that. And next, another case, if the hematocrit is falling, generally we are happy when the hematocrit is falling, but we should not. Here we should also again see the vitals. If the vitals are unstable, then we should understand there is major hemorrhage. This is a danger sign, and that patient will need urgent blood transfusion or will lose that patient. So remember, not the hematocrit falling is not always a good sign. Look at the vitals. If the pressure is falling, if the pulse volume is low, if there is tachycardia, go for urgent blood transfusion because there is hemorrhage inside somewhere. And if there is decrease in hematocrit but the hemodynamics are stable, there is interpretation should be hemodilution, and there is reabsorption of the fluid inside. So IV fluid should be stopped immediately in stepwise manners as I have described below, and ultimately it should be stopped to prevent any pulmonary edema and all these things.
Thank you, Dr. Ghosh. That is very well put. Now, what is the criteria? Now we are monitoring these children in the ward. PICU is full, the child is more or less stable in the night, but in the morning you come and see the child is deteriorated. You have to arrange a bed in the PICU. Dr. Aich, can you tell us what are the criteria for admitting a child in the PICU?
Yes, ma'am. That is a very common problem nowadays, especially in the pediatric centers that we are working now. So any child who are having a kind of severe dengue. So by means that dengue with a plasma leakage syndrome, a severe leakage of plasma, child is very hypotensive. The child is with hyperperfusion. The BP is very low, poor conscience level. So we should admit the child. Fluid accumulation with respiratory distress. Now we can detect that by means of a bedside point of care ultrasonography that can show that there is some kind of proliferation is coming out, ascites is coming out, edematous gallbladders, and we can go and this cell can be categorized as a severe dengue and can admit in the PICU. Then severe bleeding with derangement of the coagulation parameters, the PT, the APDTs, the platelets, they're all very, very poor. Then there was evidence of some end organ damage. There was myocardial dysfunction. And this one that happens suddenly. A good child suddenly becomes very bad with a elevated or palpable and tender liver. So a myocardial dysfunction, reduced urine output. So as Nilanjan said, it's very important to look at the urine output. So acute kidney injury. So signs of altered consciousness, the child is developing convulsion, very important. And the signs of developing hepatic dysfunction with the elevated AST, ALT level. And there was prolonged fever with elevated of triglyceride levels. So in that case, we can also think of a secondary and admit the child.
Yes, very good. So in the ward, if we can do a focus, a point of care ultrasound, and like you said, look at the lungs and hello.
Yes.
Hello.
Yes, Dr. Ognishekar Saha has muted. Madam, continue.
Okay, so what is important is, yes, a lot of these postgraduate trainees now are going through this focus training, which is extremely important. You know, when a child is having ARDS and having a lot of fluid overload over the night, and we can quickly do our ultrasound and look at the B lines, look at the IVC collapsibility index. There are so many ways we can actually monitor whether there's any fluid overload, and definitely abdominal compartment syndrome is another important criteria where we need to push these children into the PICU and manage accordingly. So what are the bad prognostic markers, Dr. Sinha? Like we mentioned this a little earlier. Can you just go tell us a few?
Yeah, so as you had mentioned that, in the first 3 days of illness, it is the platelets and also the albumin. So a low albumin is a bad prognostic marker. And subsequently from day 4 to day 7, it is the SGOT, SGPT, the albumin, and the bilirubin and platelets, which are the markers.
Yes, this is very important for the PGTs who are monitoring these children. Do a baseline study, look at the AST, look at the LFT, look at the bilirubin and the albumin, and of course, with all the bleeding parameters and clinical parameters, they will may give us a sense of which children are really good, may not behave very well in the next 48 hours. And these are the children needs to be monitored, maybe shifted into the PICU. So now I just want to quickly say that even losing a single child to mosquito bite is unacceptable in a country where we are sending Chandrayaan to the moon, and we need to all to work together. So there are what are the, we know the WHO protocol is all about fluid management, monitoring, look at the child, very minutely hour to hour. But even then we are losing children. So what really we have in our armamentarium? I know corticosteroids in the treatment of dengue, they have a specific protocol only with HLH, with abdominal compartment syndrome, ARDS, and mostly in the PICU setting, which my next panelist will be talking about. But yes, identifying small children who are may likely to go become sick. There are some studies which have shown that low dose steroids, they do not harm. So if we can salvage even one child, I mean, there is no PICU bed, children are getting a sense of which child will become bad. And if we need to look at this more minutely, maybe do more RCTs regarding corticosteroids in a very preliminary stage. This is something I just wanted as a food for thought for all the delegates here. We can go back to a lot of literature is coming up. So yeah, I would like to end my talk with this. Thank you to all my panelists. So in summary, I would like to say that we should suspect dengue in all cases of fever during the present season, recall of OPD patients more frequently, early early recognition of risk factors and prompt management. Monitoring by bedside is a key to good outcome and prevention of fluid overdose. Now, losing a single child, like I said, to mosquito bite, it really disturbs me. It's unacceptable. We have to fight this menace together. Vector control, public awareness campaign, government is doing its best, but we as citizens also need to put our bit together. And dengue vaccine, which we all know, it's very difficult. I mean, how will we know that a child really did not have dengue earlier? So we have to only give naive population to give a dengue vaccine, but otherwise they become more serious. Any child who has had dengue earlier, we cannot give dengue vaccine. So that is again something which is still under in being the work research is going on. And I thank all my panelists and my viewers for a patient listening. These are my sources, and thank you once again.
Thank you, Madam, and all the panelists for a very nice and lively discussion. You have covered almost all the nitty-gritties of the management of the day-to-day patient with the fever, not only the dengue, maybe the other infections at the same time. Dr. Ritobroto Kundu sir is ready. Just I want to go through 1 or 2 questions in the chat box, then we'll move to the next session. So there is one comment: USG abdomen may show fluid leakage and edematous gallbladder is the important sign, by Dr. Vasudev Patru. Yes, we already have discussed on that. Dr. Deepti Mahato has asked, sir, as there are so many DD of tropical fever and the reports of dengue and scrub typhus does not come up instantly, shall we give OPD patient of day 3-4 of fever antibiotics like syrup azithromycin along with PCM or ORS?
Absolutely not. No indication of giving an antibiotic when we are dealing. We are quite sure there is no focus. Like the definition of tropical fever is, it definitely a child comes to OPD, you look at the fever, we have to look at the throat, look at the ear infection, look at the chest. Is there any UTI? If you find that there is evidence of bacterial infection, ask for the relevant investigation. And then depending if there's a throat infection with a pus point and the child is having very severe deglutition difficulty in swallowing, maybe amoxicillin alone is good enough, but never empirical antibiotic in any of these cases. No.
Okay, thank you, Madam. And there is another question from Dr. Alok Pal. In intermittent in treatment sheet following SDB written serially, rest, no IM injection, no, that is a comment, no antibiotic, and please keep inside the mosquito, please keep inside the mosquito nose. That is the comment from Dr. Alok Pal. And
very difficult with children. The dengue Aedes aegypti bites during the daytime, and the children were putting them inside the mosquito net throughout the day. It is recommended, of course, but if you can do it, it's good. But difficult for the children to be confined to the mosquito net during the daytime.
yes. Okay, so I think we can move to the next session now. So for the next session, mainly the discussion of the different variable clinical manifestations of the dengue at present moment that already started this. They have some discussion in the beginning of the session that there is changing pattern of the clinical manifestations of the dengue. To discuss on that for this moderators of this session are Professor Sukanta Chatterjee sir and Professor Kalpana Datta madam. Over to you, Professor Kalpana Datta madam and Sukanta Chatterjee sir. Please introduce our esteemed speaker for this session.
So I request Dr. Sukanta Chatterjee, the ex-WB president and the present president of AHA and consultant, to introduce the speaker, our very own Dr. Ritobroto Kundu.
Thank you, Professor Kalpana Datta. And it's a privilege to introduce Professor Ritobroto Kundu, who is my old friend and at the same time having a long clinical experience. And it's no wonder that he is the fittest person to describe the common and uncommon clinical manifestations of dengue, with which disease we are rather so-called ghar kora in Kolkata with dengue. So Ritobroto has got a long career, and he especially if one point I should mention, his special interest area is, of course, infectious disease, and he was chairperson of the infectious disease also. And I request Professor Ritobroto Kundu to present the clinical features, which is the mainstay of diagnosis, and that is what the people is also expecting, that looking at the patient, you will consider that it could be dengue and go for investigation. Yes, Dr. Kundu, please.
Shall I share the screen now?
Yes, please.
So am I audible and visible?
Yes, both.
So dengue for the last few decades has exponentially increased. A disease which was localized to the Southeast Asia has now gone as far as Western Pacific, across the Africa, even to the North and South America. I'll be coming to this little later. So all of you know, as previously told, dengue is a flavivirus. A flavivirus is an arthropod disease, bone disease, which is carried by the bite of a mosquito. The two important flavivirus which we have in our country is dengue and JE. They share something in common. Both of them, to start with, presents with a systemic febrile illness. And during this period, it is virtually impossible to diagnose from any other viral fevers, excepting there are certain subtle clues which you need to find out. This systemic febrile illness is followed by organ-specific manifestation. In dengue, the viruses affects the capillary endothelial cells. It has predilection for two sites. One is the pleural space, another is the peritoneal space. The capillary damage it causes is functional, because even if you don't treat dengue, quite a good number of cases will revert back. And it does not leave behind any sequelae. So it does not cause any structural damage. But if you consider the another flavivirus, Japanese encephalitis, it affects the central nervous system and cause irreversible damage. But this was what we are taught a few years back. But now there are several reports which have shown that dengue has invaded the central nervous system. Dengue encephalitis, dengue encephalopathy. We have so many other things. So things are not that simple we thought previously. So coming to my first case, a 3 and 11-month-old child presented with sudden onset fever with erythema. You can see the flushing attack he has in the face and the trunk and the limbs. This can be both a morbilliform or a scarlet-lentiform rash. He has body ache, arthralgia, his conjunctiva and pharynx is injected, he is vomiting and he is anorectic. So if you find this case, it can be a manifestation of several diseases. Of these two diseases which I have told you, morbilliform, that is measles, and scarlet-lentiform, that is scarlet fever. In measles, it is rhinitis, watering eyes, hacking cough, which predominates the situation. But in dengue, you can have a injected conjunctiva, injected oral cavity, but you don't have that sort of cough, that sort of watering eyes or running nose. So it can be taken as a dry measles. This is a very important point. In scarlet fever, which is a streptococcal bacterial infection, sore throat will predominate the whole scenario. But in dengue, you can have muscle aches, but not sore throat. Another very important differential diagnosis, which is the flu. Flu in our Eastern India is a monsoon disease. And in case of flu, it is the cough and the rhinitis, which is a predominant symptom. Along with, there can be myalgia, there can be body pain and fever. But in dengue, it is the myalgia, body pain, which will be of more prominence as compared to cough, and rhinitis usually don't happen. But at times you can have a double attack of both dengue and flu, then it is very difficult to diagnose clinically. And at this stage of the disease, it is not possible to say whether how the disease will progress. You cannot assess the severity in so early stage. So our child on the third day, his hemoglobin was 13.2, his PCB was 42, total count was 3,800 with 44% lympho and 46% neutrophil. Platelets were 1,22,000. His NS1 antigen was negative, but dengue, both IgG and IgM was negative. So as you all know, NS1 antigen is a protein, glycoprotein antigen, which is very species specific. It is not shared with all flavivirus, whereas antibodies are shared with all virus, flavivirus. So if a child who is suffering from dengue has got a Japanese encephalitis vaccine 1 or 2 months previously, his IgG and IgM pattern will be somewhat deranged, not like primary and secondary dengue. But the NS1 is not shared by any other flavivirus, but the sensitivity and specificity of the NS1, which depends upon an ELISA test, is not very high. And that's the reason why these days, in many places, it is a dengue PCR which has come up. In the southern states, already in good hospitals, corporate hospitals, they have left behind NS1 antigen and they are doing dengue PCR. And we will be, hopefully, we will also have dengue PCR very soon. So after 2 days, the fever subsided and the patient improved. So this is a classical case. So another important point I'd like to tell you, does all dengue patient will go to critical phase? No, not necessarily all dengue patients will go to critical phase. This is a classical case of undifferentiated dengue fever, which does not go. In places where laboratory support is poor, tourniquet test is one of the tests which gives a very early indication whether the child might have dengue. So this is the tourniquet test. What you do, you inflate the blood pressure cuff in between systolic and diastolic pressure, keep it for 5 minutes. And then count in 1 inch squared area how many petechiae are seen. It is in early stages of dengue, you can have few petechial spots, but if the child has a dengue hemorrhagic fever, then the petechiae will be very high, more than 20. But again, a children who has dengue shock syndrome or dengue with capillary leaks, these tourniquet tests might not be positive. So it gives a very rough estimate. It is not a very good clinical feature to, if it is positive, you think of dengue. If it is negative, you not necessarily that you don't think of dengue, you also think of dengue. So this what I was telling you, it is a primary in cases of undifferentiated dengue fever. Rash may or may not be present, and the child never goes into the capillary leak syndrome or bleeding phase, and it heals by itself. So most of these undifferentiated dengue fever are not diagnosed as such as dengue itself. You can have this flushing attacks. You can see the mark in the limbs, mark in the trunk, like this. So previously what was done, previously World Health, we had a classification of dengue, undifferentiated dengue, dengue with shock syndrome, dengue hemorrhagic fever. But this classification was not at all good because of several reasons. One of the most important reasons were we could not place the patient in any one group. Patients might have features which resembles multiple groups. So that's the reason World Health Organization has now come out with a very simple classification, that is dengue with or without warning sign on one side and severe dengue on the other side. So dengue without warning sign, the most important feature in the diagnosis of dengue is the epidemiology. It is during the monsoon season, and you will have similar cases occurring in the vicinity. These are the two very important things. Any child during the monsoon season with cases occurring in the vicinity comes with fever, you should think of dengue. And your suspicion will be very high if the child has rash, if the child has aches and pains in the body. So these things, these are the dengue without warning signs. But if the child has abdominal pain, everybody knows. But if you put your hand on the abdomen and the child winces, that is abdominal tenderness. I have seen one case where this was diagnosed as acute appendicitis and was operated upon, only the child died of dengue hemorrhagic fever later. So abdominal tenderness is extremely important. So also persistent vomiting and mucosal bleed. A few petechiae here and there does not suggest that it is a severe dengue. It can be a manifestation of non-severe dengue, but mucosal bleeding or mucosal purpura, especially epistaxis, little bit of gum bleeding might not be of that significant, but major bleeding, these are very important sign of danger in dengue. And fluid accumulation, as you can judge, there are two important sites where the fluid accumulates. One is the pleural cavity, another peritoneal cavity. But when your diagnosis fluid accumulation clinically, the thing is little bit late. You have to pick it up much earlier. And if the child shows signs of restlessness, lethargy, these things. And if you find an increase in the liver size from the baseline more than 2 centimeters, these are all dengue with warning signs. So chances of dengue with warning sign and dengue without warning sign going to severe dengue, both of in them, the chances are there. But if you see the arrow, where from warning sign to severe dengue, the arrow is much thicker, and the arrow without warning sign is much thinner. So the chances of going to severe dengue, it is much high with those with warning sign. And severe dengue incorporates 3 important things: severe plasma leakage, hemorrhage, and organ impairment. Plasma leakage, everybody of you know how to see and what to do. And I'll be talking a little bit about the severe hemorrhage. Most of the dengue hemorrhages are either from the nose or from the gastrointestinal tract. And if it is an adolescent girl, then they can have menorrhagia. At times, they can have also hemorrhages in other sites, pulmonary hemorrhage, intra-abdominal hemorrhage, and these are known as concealed hemorrhage. This is a very sinister sign. If you cannot pick up, then the child is going to die. Of the severe organ impairment, there are 4 organs which heads the list. Heading the list is first the liver. The SGPT and SGOT lies more than 1,000. There can be an enlarged liver with tenderness. There can be signs of fulminant hepatic failure. The next organ which is involved is the central nervous system. Starting from restlessness to energy, apathy, convulsions, everything can occur. And the next is the cardiovascular system, where you can have usually conduction defects, most of the cases present with bradyarrhythmias. And along with that, you can have also myocarditis. And the last is the renal function impairment, where there can be an acute renal shutdown, or the amount of urine pass is gradually decreases because the kidney is failing. So as years and years has passed, in the last few decades, we are recognizing certain very unusual and uncommon signs in dengue. Previously, these things were thought never to be a part of dengue. Way back in 2008, World Health Organization has coined a term, expanded dengue syndrome. These are the signs and symptoms which were thought to be unusual and uncommon, is now being found in dengue. Of the neurological signs, it is the encephalopathy, encephalitis, aseptic meningitis, everybody know. But dengue can also lead to Guillain-Barré syndrome, transverse myelitis. In the gastrointestinal tract, All of us know that there can be an acute fulminant hepatic failure can be there. So also there can be acalculous cholecystitis. But there are very two important things which can occur in dengue. One is pancreatitis, another is parotitis. So remember this. In the kidneys, as I've told you, you can have an acute renal shutdown. Also, you can have hemolytic uremic syndrome, dengue, followed by hemolytic uremic syndrome. In the heart, there can be all sort of conduction defects. Mostly they are bradyarrhythmias, and they can also land up in acute myocarditis. ARDS is sometimes seen in the respiratory symptom, and so also pulmonary hemorrhage. In the musculoskeletal system, rhabdomyolysis can be seen at times in dengue. And the most important finding in the lymphoreticularis system is dengue leading to HLH. Dengue leading to HLH, dengue leading to ITP, these are found in the hematological system. Optic neuritis, dimness of vision can be seen in the eyes. Dengue can lead to psychosis. Dengue can lead to fatigue syndrome. So there are a host of signs and symptoms, and they are known as expanded dengue syndrome. You should never forget this. So the most important thing when you should think that you are dealing with a very serious dengue, any dengue patient coming at the extremes of the age, either infants or old age. A child with an attack of dengue in the past will usually suffer from severe infection, which I'll come a little bit in detail later. And also a newborn who is born with maternally derived antibodies against the dengue, if develops dengue, it will be very severe. Secondary infection developing in dengue will increase the severity. And another very important thing, if two serotypes are circulating simultaneously and you are infected by them, then your chances of having severe dengue is very high. If serotype 1 is followed by serotype 2, the chances of developing acute hemorrhagic fever increases by 500 folds. Vis-a-vis, if serotype 4 is followed by serotype 2, the chances is only 50 folds. And also remember, it is the chota dengue and the mota dengues. These are usually very serious. Any person who is coming from a country where dengue is not an endemic, if he suffers from dengue, invariably it will give rise to very serious virus strains also matters. Fortunately, the type 2 virus usually does not cause primary. It causes secondary dengue, and it is very serious. Any secondary dengue which is caused by type 2 virus. So this was I was telling you, initially it was in the Southeast Asia, now has gone to the Western Pacific part of Australia, crossed Africa, and has affected part of the North America and part of the South America. So in fact, the dengue has spread exponentially in the last few years. And as I was telling you, there are 4 types of dengue virus. And the antibodies we produced against the dengue virus is homotypic. They are not heterotypic. Supposing if you have an infection with dengue 1 virus, your antibodies will be produced only against dengue 1. Supposing if you have a dengue virus in this year by type 1, and in the next year you have a dengue virus infection by type 2, your T lymphocytes is being taught to produce antibodies against type 1. They will not produce antibodies against the newly infected type, that is type 2, but they will produce antibodies against the type 1. The original sin which you have committed in the yesteryear, they will produce against that. So the entire effort of the body's defense will be misguided. And that is the reason why in case of secondary dengues are much more severe as compared to the primary dengue. So remember one thing, the antibodies in dengue are homotypic, not heterotypic. So this is the Aedes aegypti mosquito. This mosquito has very peculiarities which other mosquitoes don't have. They have a flight range, very short flight range, just few meters above Neeraj Chopra's record. 88, they have a flight range of 100 meters only. They are anthropophilic. That means they love human being, bite. They are not zoophilic. They never bite animals. Number 3, they are very nervous bite, nervous suckers. Whereas other mosquito will be satisfied with a blood meal from a single human, because the blood meal from a single human will enable the mosquito to mature the eggs. But this Aedes aegypti, they require multiple blood meals for multiple involves to have their eggs matured. So that's the reason, because of the short flight range, because of its anthropophilic character, and because of its the tendency to bite different, they spread very rapidly, and they spread in clusters. You will have, supposing our whole South Domson municipality is affected with dengue this year very much, but the focus is in certain clusters, because the spread of the virus, because of the short flying range of the mosquitoes, they are located like that. So does one strain give cross protection to other? As I've told you before, no. And the most important thing which I'd like to discuss now is dengue in infants. It is an enigma. It will baffle us.
Sorry to bother you, just you have 5 minutes more.
But I'll try to do it. So they will baffle you in the clinical features. They will baffle you in the laboratory, in everything. The most common presentation dengue in infants are 3. One is simple febrile seizures. Number 2, vomiting and diarrhea, and cough, cold, and coryza. The flushing attacks you see in older children, you won't see in infants. If you do a blood test, in the early phases of dengue, in the blood test, you expect leukopenia, but here you won't get leukopenia. In fact, you will get leukocytosis in most of the cases. And they are often, because of this high leukocytosis, high CRP, they are often confused with bacterial septicemia. And the chances of dengue going to dengue hemorrhagic fever is very high in case of dengue in infants. So during the monsoon season, when dengue is occurring, any child in between the age of 4 to 9 months coming with fever, be it from any reason you think of dengue always. And also another very important thing is dengue in the neonates. A mother who is suffering from dengue 10 days before and 10 hours after delivery, 10 days before and 10 hours after delivery, will transmit the dengue virus to the newborn. The chances of transmission varies from 1.6 to 64%. The severity of the disease in the mother, the type of delivery does not affect whether it will be getting transmitted or not. But the chances of transmission varies. Exactly what is the reason for this variance, we don't know. But most of important thing in the neonate, they will present with signs of bleed, circulatory failure, thrombocytopenia, bleeding manifestation will be there. Another important manifestation is they will present just like septicemia, and at times they can manifest with central nervous system problems. So coming to my 2 cases, I have a 2 months old girl, fever for 3 days, not associated with upper respiratory tract, congested throat, few petechiae, seen in the 2nd day of life. Any child who comes with petechiae, think of 3 very important things. One is dengue, another is meningococcus, another is scrub typhus. And don't forget to exclude these 3. Multiple episodes of non-bilious vomiting, drowsy, didn't pass stool for 10 hours, weak pulse. We did an IV line, a bolus, normal saline bolus was given, transferred to PICU, first dose of antibiotic given. Normal saline was given in 8 ml per kg per hour, blood investigation sent. The first blood investigation shows total count of 13,000 with 49% lymphocyte that goes in favor of dengue, low neutrophils, relative lymphocytosis, hemoglobin 16.2, PCV 48, platelet 25, follows dengue in all way. CRP not that high, urea, creatinine such, sodium, potassium was there, and NS1 was positive, dengue IgM, IgG was negative. This is the X-ray. What the X-ray shows, you can see fluid accumulation is there. So the child has started dengue shock syndrome or dengue leak syndrome. Same day in the evening, there was marginal improvement, better pulse and perfusion. The urine volume was 1.3, BP was 86/17. Follow comments, drank some water, blood sent for hemoglobin, PCV, and platelet. So the report came in the 10 in the evening. Hemoglobin was 14.4. Platelet slightly risen. The PCV has come down from 48 to 43, and we are very happy that things are improving. But at 1 o'clock in the midline, again the child started tachycardia, tachypnea deteriorated, NS bolus given 20 ml, IVF was increased, hematocele was given, a blood report was done urgently, hemoglobin showed 13.8, PCV 31, platelet 13,000 slightly increased. We thought its status, no, the status didn't improve. Any child who is presenting with tachycardia, tachypnea, sudden fall in the PCV, always think of dengue hemorrhage. There was certain deterioration. It was a concealed hemorrhage at 4 p.m. Desaturation, tachycardia, tachypnea, bleeding from mouth and nose, oozing from the puncture site. The child collapsed, intubated, ventilated, and this was the complete whitewash of the lungs. And ultimately, after a very tormented period in the PICU, the child was survived. So think of concealed hemorrhage, which is the most important serious complication. If there is a fall in hematocrit with overall improvement, refractory shock with falling hemoglobin, hypotensive shock at presentation, abdominal distension with tenderness associated with or without metabolic acidosis in a shock, think of concealed hemorrhage. I'll come to the last 2 slides. This was the child we saved. This is the next case, 10-month-old child with fever for 4 days, poor intake. Next day, generalized rash which subsided within 24 hours. Fever continued with vomiting with loose stool, fluid intake poor, scanty urine, dry coated tongue, lethargic, generalized tonic-clonic convulsion, in emergency unresponsive with jerking limbs, temperature was low, pulse rate was high, BP was this, SpO2 was 94 in room here, neck stiffness was there, low frontally depressed, labored respiration, feeble pulse, cold extremities. So if you interpret the history is that of an acute febrile illness with less fluid intake and fluid loss resulting in dehydration. Clinical signs of shock includes tachycardia and decreased peripheral pulsation. Seizures, the child had maybe due to ischemia of the brain, maybe due to meningitis, encephalitis, or maybe due to electrolyte balance. In any child, if you see a seizure with neck stiffness, your first thing, you will think that it is a case of meningitis or encephalitis, but subnormal temperature makes the diagnosis less possible. So subnormal temperature means the child has already entered into the critical stage of dengue with increased vascular permeability, plasma leakage, and hypovolemic shock. The patient probably now has had dengue with shock syndrome. Next day, this blood tests were done, blood samples done, IV ceftriaxone was started, and this was in the PICU. This is my last slide. Only responsive to pain, occasional decelerate posturing, heart rate was 130, normal respiratory effort, temperature was still low, BP was like this, cold extremity, feeble pulse, increased CRT, pupils unequal in both sides, anterior frontal sunken, petechial hemorrhage with bleeding in the IV sites. We did a report in the emergency department has come, hemoglobin 10.8, PCV 33. It was a decreasing PCV with leukocyte count 15,200 with a high lymphocyte. So it is very unlikely that it will be due to infection. The platelet was 24,000, SGPT, SGOT raised, sodium low, potassium raised, INR 1.7, PTT very high. And all this venous blood gas shows severe metabolic acidosis. So this is not infection in spite of a high count because lymphocyte is more. It is a dengue shock syndrome with hepatic failure. His INR, PTT, everything is right. So also SGPT, SGOT. So this is a case of very severe dengue, and unfortunately we lost this child. So with this, I thank you for your patient hearing. Thank you all.
Thank you, Dr. Ritubrat Kundu, for a nice galaxy of cases of different varieties and enriching us with the different cases and also the different presentations. We learned many new things like on the cardiac disorders, like the newborn presenting with the congenital vertical transmissions, and there are lots of cases you have explained nicely. Is there any questions you can ask Dr. Kundu? He will, sir, you can answer in the chat box so that we can go for the next session. Before that, I'll request Dr. Chatterjee to say a few words if you want to say, sir. Then we'll hand over the mic to Mihit for next session.
Yes, I think this is a very time appropriate session that we are conducting. Particularly, all clinicians must be very vigilant about the clinical signs and clues. That is very important. If there is any suspicion in this season, go for a dengue test and confirm it and follow it up. Thank you. I think that is the message that Dr. Kundu has carried through all these 30 minutes. And thank Dr. Kundu for this nice presentation.
Thank you, Sukantada, for your always active support for me. And thank you, Kalpana, and thank you, whole IIP, Mihir, and others also.
Excellent.
Thank you, sir, for excellent session. So moving to the next session, that is slight change in the plan. So now we'll move to the over to Dr. Dipankar Majhi, sir, for just briefly discussing on the operational aspect, what the government of West Bengal is thinking, what is the present epidemiological status and difference in the serotypes that are going on in the circulating in our in the West Bengal, and different operational aspects. So to discuss on that, we have I welcome Dr. Dipankar Majhi. I had very brief discussion on the operational overview.
Thank you. Can I have the slides? Thank you. So am I audible?
Yes, yes.
Okay. So a very good evening to all of you. Just a brief discussion about the epidemiology that we are coming across, and also some operational aspects that we have gathered from our experience of dealing with dengue for last several years. Next. Slide is not moving. Yes. I will just quickly touch on a few points in this slide. Yes, in West Bengal, no district is spared from dengue. That is one important point. Over the years, dengue has moved to virgin areas by now, because since 2022, I mean last year and this year also, we have got a good number of dengue cases even at the altitude of Kalimpong and in the Duars areas also, good numbers. Mostly the disease transmission is predominant in Kolkata and the surrounding districts, but even in districts like Malda and Murshidabad, where the environmental condition is very congenial for mosquito breeding, Aedes breeding, a good number of cases are occurring also there. And from these main hotspot areas in and around Calcutta, now the disease has progressed to even the less known areas or less endemic areas, and no district is spared now. Okay. So next slide, please. So a few words about the serotype. In West Bengal, all 4 serotypes are found, and there is co-circulation of different serotypes in some areas. You can see just the previous slide, previous one. So from this graph, you can see the 4 serotypes have been shown in 4 colors. Now, there are so many ups and downs over the years. That means in some year, one serotype is high, others are low, and within just 1 or 2 years, that high one comes to a low and the low one goes up. So that seesaw game is there. But one interesting thing is in 2022, you will see DEN 2 and DEN 3 both have come very close to each other last year. That means in many areas, there were co-circulation of DEN2 and DEN3, making these two the most predominant serotypes. Next slide, please. Next one. So in 2022, we got a good number of DEN3 and DEN2. Overall, DEN3 were more than DEN2, but interestingly, in North Bengal districts and in Nadia also, a part of Nadia, DEN2 was more, and in the southern Bengal, DEN3 was more. In 2023, I mean this year, the situation has become more complex. One thing is, good thing is, in North Bengal, DEN2 is continuing. That is why we are getting very few fatalities from North Bengal. But in southern districts, two things have happened. In some districts, there is co-circulation of DEN2 and DEN3, almost equal to each other. And in some other districts, the DEN3 predominance has gone down and DEN2 has come up. That means people who were earlier affected by DEN3, now in this year, they are getting infected by DEN2. And these complexities of serotype, the serotype game can explain why so many complicated cases and so many fatalities are occurring. Okay, next slide. Next. There are two things that I have understood in my limited clinical experience in dealing with dengue. That one is the early part of dengue shock. When the shock is in compensated phase, it is very difficult if the clinician is not cautious enough, is not meticulous enough, he may miss the shock when it is in compensated phase. And treatment, adequate fluid therapy in the compensated shock can prevent a lot of complications. This is one side. And on the community side, some of the warning signs are so trivial in nature. Apparently they are trivial, but actually they are warning signs of dengue. I can give you an example of repeated vomiting or prostration or dizziness. In common people's mind, it appears that, these are very common things, common problems in viral fever. So initially, even if this type of symptoms are there, they may overlook, they may neglect the warning sign, and they'll end up with too many complications when they arrive at the hospital. So missing some of the warning signs is very important here, and this is one area where our message to people should be very loud and very specific, particularly harping on these apparently trivial things. Next slide, please. This is the top sheet that we are following in the government sector. It is mandatory in all government hospitals that if any suspected dengue or confirmed dengue is admitted in ward, the bedded ticket of the patient will have one top sheet. This is just a summary of the monitoring indicators. Next, please. This year we have given much importance on early testing. According to the public messages that have gone out from our department, if fever does not subside within 1 or 2 days, please come for dengue tests. And this testing facility has been increased manifold. Last year we had only, say, a little more than 100 testing facilities in government sector. This year it has gone way beyond 250. And apart from these hospital-based testing centers, we are collecting blood samples from fever camps also. Dengue test, even with the slightest suspicion and in the early phase of this. Okay, next slide, please. Next, please. now this the issue that we have been discussing from the very beginning, that the changing clinical practice feature from 2019 particularly, this has been very conspicuous, that this organ involvement has become very important, and dengue has its own problems with shock and hemorrhage. But beyond shock and hemorrhage, this vital organ involvement has to be given due importance, and our clinical management will not be enough by looking only the hemodynamics, but also for the organ functions. And adequate laboratory support and investigation facilities must be there for doing this type of tests in cases where they need so. And at the end, I preach for finding of new drugs, RCTs on steroids, role of steroids in dengue, because probably you know that we review the treatment records of all reported dengue deaths, and from that what we have gathered, that there are many dengue deaths where shock or hemorrhage was not the cause of death, and there were enough evidences to suspect cytokine storm or sepsis. So use of steroid, use of other newer drugs, there is a lot of scope to think about it, and I think it's a good platform where as a public health specialist I can implore you to think of it and get into some research which can throw light on it and for better outcome in the coming years. Thank you, sir.
Mihir, you unmute.
Yes.
Unmute.
Yes. Thank you, Dr. Deepankar Maji. So Dr. Deepankar Maji is the main pillar of the dengue management of the government program of the public health issues and regarding the dengue from our Shastro Bhavan headquarters. So very nice overview of what is happening in the state and what we are thinking, and for encouraging works for further research in the dengue with the new drugs like steroid or other biologics. Now I
Mihir,
yes.
Can I make a comment specifically for Dr. Maji, since he is here? Hi, Dr. Maji. I'm Dr. Agnishekhar Shah. I'm a pediatric intensivist. Has been working with all of it, and we see what you have just touched upon, that most of the dengue deaths in pediatrics, they happen related to it's got various names. Some call it HLH, some will call it cytokine storm, some call it so, but it's basically the same thing. And those conditions actually need stuffs like steroid, IVIG, and then maybe extracorporeal therapy, anakinra, those sort of stuffs. And actually, to be honest with you, even we do not know what is the right way to treat it. We are also exploring. And when I say we I mean the medicine as a subject, pediatrics as a subject. So maybe if that can be incorporated in the government sector, because sometimes when we use this, I'm just talking, I believe, on behalf of all of us, that we often find a bit sort of hesitant that how the government will look at it, because it is not there in the guideline. And I have found people to be very hesitant to use it, although there is evidence for its use, not in all cases, but in very selected cases. So maybe if you can sort of look into that, and maybe at least assure us that this we will be following the government guidelines, absolutely. But then on top of that, at least some kids may need more. And if we do that, that does not mean that we are breaking the government guidelines. If a message like that comes, I think many doctors will feel reassured.
Sure, sir. Sure. Actually, the new guideline that has been used this year we have updated training PPTs, and very soon we are bringing out our new printed guideline also. There you will see this HLH has been included, and definitely there is specific recommendation for steroid, and definitely we look forward to include other biologicals as we keep on gathering more evidences. Thank you, sir. Definitely.
Thank you.
We'll keep
Thank
it.
you.
Okay, now last part of this today's dengue symposium is the severe dengue one, the severe patient who are just landing to in emergency or in ICU or in HDU. And to discuss on that, we have Dr. Ognishekar Saha, who is the moderator of this session, who is the pediatric intensivist and at Apollo Multispecialty Hospital and Institute of Childhood. We all know Ognida. And over to Ognida to start the session. And panelists are Dr. Shaumen Meur, Dr. Prabhas Prashungiri, Dr. Satyabrat Rai Chaudhary, and myself.
Can I share my screen here?
Yes, yes. There is a green button there is the share screen.
Yeah. Right. Yeah. Am I audible and is the screen visible?
Yes, yes.
Right. Okay. Let's start. Since we are running quite late, again, thank you to the organizers for having all of us. I'll be moderating, and as Mihir has already introduced, I mean, Mihir himself, Dr. Prabhas Prashungiri, Satyabrat, and Dr. Shaumen Meur, who are the panelists. And we'll be mostly talking about the management issues of severe dengue. Let me start my timer. Rough timer here. Where is it? Start. Yeah. So start with a case. We've got a 5-year-old, weighing 35 kilo. The previous history of dengue, NS1 positive on day 3, antibody positive on day 6, afebrile since day 5, and today is day 7. So we are on afebrile day 2. And he has been receiving fluids at 3 ml per kilo per hour, as is often said. We almost never say express fluid in this way, except in dengue. In dengue, we often use it like ml per kilo per hour. So it's 3 ml per, but here, these people, they have used ideal body weight for a 5 kilo, which is 18, although the actual body weight of this kid is 35. And so they went by ideal body weight, and they're giving it 54 ml per kilo per hour, going by ideal body weight. His last PCV was 38, and that was day before yesterday. His current blood pressure is 90/60 with a mean of 70. His heart rate is 145. He's 5-year-old. He's cold centrally and peripherally. His peripheral pulses are weak, although his central pulses are okay. He's breathing fine, but he looks pretty lethargic. What information, important information is missing in all of this? And what has already been done? What one component could have been done better in this patient? Let's start with Satyabrat.
Yes, thank you, Ognida. So clearly this child is not hemodynamically okay. So child is developing compensated shock at this stage, and we have these parameters like blood pressure and heart rate, everything. But one parameter I would like to know is about urine out. That is missing in this area, and that is very important for this child to assess.
Absolutely. Hello.
Hello.
Yeah. Sorry. So urine output is missing. Absolutely. And what else could have been done better, do you think? I mean, in terms of what information you have got so far. So this kid is in shock. If
we want to know the urine output, and the child is hemodynamically deteriorating, we need to catheterize the child so that we can measure the urine output toto. Because without catheterization, it is not even sometimes possible to measure it uh, accurately, especially in intensive care.
Absolutely. And the other thing was the PCV that I mentioned, that was day before yesterday.
Day before yesterday, so I need a current PCV for the child, so it is
Patient who
increasing or
is
decreasing.
ephemeral and who is going into the danger period, you cannot really wait for 48 hours before repeating a PCV. That simply should not be done. You need to, at least on those 3-4 days of ephemeral illness, you should record your PCVs at least daily, if not 12 hours. Right. So in such a case, what should be your immediate steps? Who will take this? Maybe Mihir. So what will do in this patient, Mihir, immediately?
Yes, so it's very so what are the things before, besides the urine output and the hematocrit, as the patient in front of me, I definitely like to see other vital parameters. What about the respiratory rate of the patient, if there is patient having some respiratory distress as well, or the 145 at 5 years of age, a bit tachycardic patient. If that patient don't have any fever at this point of time, I will consider as definitely patient tachycardic. So definitely I will try to rule out if this patient have any sort of cardiac involvement at this point before going to further fluid. If the patient is not with that, then the patient is in blood pressure, though more than 5th centile, but the tachycardic periphery is cold. I will increase the and hematocrit I look for. If the hematocrit rises 10 to 20% or the urine output is less than 0.5, I will titrate the fluid to increase to 5 ml per kg per hour at this present moment. Again, then reassess the patient after 1 hour. What is the urine output? What is the pulse volume and the pulse pressure of this patient and BP? And that's how I will continue. So hourly urine output monitoring, checking the systolic as well as diastolic and the pulse pressure, and the parameters like the capillary refill time or the pulse volume are very important points to be monitored here. And also simultaneously looking at the if there is any kind of cardiac involvement here, as you have found that this time in this we are not getting very capillary leak type of patient presenting with shock, but maybe some myocardial dysfunction, early association may lead to hemodynamic deterioration. That I will look continuously for this patient and monitor.
Fantastic. So Mihir has at the same go has also answered the next question, which was how will you monitor? So that's nice. And then the other thing is PCV. Mihir, in this patient, how frequently will you do the PCV? I mean, PCV is also another important part of monitoring, isn't it? So how do you decide how frequently you want to do the PCV?
Yes, so PCV though at this every point when you are changing the fluid, it is very impractical to do the PCV all the time point you change the fluid because the yes, so and even with the higher tertiary care, it is not always possible every 1 hourly or 2 hourly, because you have to titrate the fluid in a sick child very frequently. So that is the one point. So in our practice, we used to do it at least 12 hourly in patient within admitted patient, and mostly we can do 6 hourly, not before that. So how we can titrate the fluid and monitor the patient? It is the urine output, it is the blood pressure and the pulse pressure, other parameters like the heart rate and the pulse volume of the patient. Is there is other features of capillary leak is increasing, like ascites is increasing, or the patient having pleural effusion, respiratory distress is increasing. That's how we'll monitor.
Okay, fine. So the case continues, and we're 10 hours down the line, 10 hours after this point in time. He is now on 144 ml per hour. So that comes to about 8 ml per kilo per hour as per the actual body weight, ideal body weight. But he's now on needing a little bit of oxygen, nasal cannula, 2 liter with some recession. His peripheries are now warm. His sensorium is alert. Previously, he was tired. His blood pressure, the mean is still 70, but the blood pressure distribution is 100/55, which was 90/60 previously. And his heart rate has come down from 145 to 100 per minute. His urine output for last 6 hours is 0.8 ml per kilo per hour. Remember, this urine output, we never measure it by ideal weight. The urine output, you always measure it by actual weight, isn't it? So, and that's 0.8. So what did you do now? Why? And what important information is missing from what has been given already? This is for Provash.
Okay, so if we are dealing this case for the last 10 hours almost, and if you see that the blood pressure has been improved, the pulse pressure has improved, the heart rate has decreased, the feel of the patient has been improved, the peripheries are warm, sensorium is alert, and the urine output is adequate. In dengue, we usually target 0.5 to 1 ml per kg per hour. And now in the mid recessions with the with oxygen requirement. So I think that is perfusion wise is perfect, and it's the time to possible we need to think about reducing the IV fluids. But before that, I need to know that the baseline PCB and what the PCB at this moment of time, and definitely depending upon that, if it's matching with me, then I will definitely go down on my IV fluids. I don't want to make this patient overfluid.
What one point, if I wanted to tell me about one point which will definitely make you come down on the fluids, which one point?
Yeah, definitely. Urine output.
Urine output is good, but this kid is now needing oxygen.
Oxygen is there. So most likely is having some features of fluid overload is there.
Exactly. Yeah. So, take home message which has already been, shared by all my esteemed panelists, that, once you initially be absolutely liberal with fluids, that's fine. But once your perfusion is good, it's very, very important. That is what we have learned over the years, that it is also extremely important to back off, to cut down your fluids accordingly. And then the urine output, a lot of people say it's still not 1 ml per kilo per hour. Look, if the smaller kid, it needs to be closer to 1. And for larger kids, and especially for obese kids, which is this kid, he's a 5-year-old, but he's more than 30. So for obese kids, you don't need 1 ml. It can be considerably less than 1 ml, and that still can be pretty good. And beware of signs of fluid overload, which is often respiratory. Now, in a separate world, for the same kid, after 10 hours, he is still on 144 ml per kilo per hour, so 8 ml per kilo, and he is still needing a little bit of oxygen at 2 liters per minute, and he is having some recessions. These 2 points are the same, but for the other points, they are a bit different. The peripheries are still cold, centrally warm. His sensorium is still tired. His blood pressure is now 65 mean with a distribution of 85 by 55. And his heart rate is now 148, which is almost same as 145, which was 10 hours ago. And his urine output has been 0.3 ml per kilo per hour, right? So, and we have been on 144 ml per hour of fluids. Are you happy? And what is the problem here? This one is for Dr. Meur.
Thank you, Agni. Yes, I'm not happy. I never am. So this makes it even unhappier. Obviously, this kid is not in a very good shape. Despite having significant fluid resuscitation and ongoing fluid management, the parameters are still pretty poor. The blood pressure is relatively low. It's still probably acceptable for a 5-year-old, but the pulse pressure is okay. But the heart rate, I'm very concerned about, 148. It has gone up. It was 145 before, and also very concerned about the urine output. It's 0.3 ml per kg per hour is not really acceptable. So it's going on to AKI territory. So what exactly is the problem? Can be a multitude of problems. One is I'll go back to checking the heart again. Dengue can affect practically all organ systems in our body, and dengue myocarditis is something that is seen, I would say, more frequently than we recognize. Some of them are very mild and doesn't need any particular treatment, but I think in this kid, I'll definitely think about myocarditis. Fluid overload is also another point, because if we have given too much fluid and there is fluid collection in pleural space, in pericardial space, if there is a large ascites, that will impact the venous return and cardiac contractility significantly, and that can lead to this picture. There may be a relative volume overload rather than volume deficit. And also at this stage, if the fever were persisting, I'll think about the complications of dengue that we often see. Having said all these things, I would like to optimize the perfusion bit first, because if my urine output is 0.3 ml per kg, if my blood pressure is falling, if my tachycardia is persisting, I'm fairly certain that my cardiac output is inadequate, and I need to optimize that with some intervention. Bedside
We'll come to
echocardiogram
the
focus.
intervention a bit later.
Okay.
So just one to sort of, again, what Shomenta has already said, but for the audience, I mean, this is possibly the most important take-home message, especially if you are working in a peripheral centers. Then, this combination of fluid overload and at the same time bad perfusion. These are the bad patients, right? When you have already features of signs of fluid overload, a bit of bloated abdomen, a bit of respiratory distress, and at the same time, the kid is not well perfused. These are the patients who will give you grief. These are the patients who are going to need very intensive therapy. So beware of these patients, and if you need to send them at this time. Maybe it is already too late, but if you wait further, it will definitely be too late. So if you are okay to sort of, manage such patients, feel free to do that. But if you think, no, I do not want to handle a bad dengue, then these are the patients who need to go. It's very important, right? So
there is a question from audience, why not capillary leak at this stage? So probably, yes, you be asking about the colloid, if we can consider if there is capillary leak is persisting at this point of time.
Coming to that. So in such a patient, what are your options? I mean, what can you do? Maybe just Shomenda, just continue. You are coming into this. I just stopped you just to make that point. So what will you do?
So as I was talking earlier, bedside ultrasound is absolutely, I would say, essential at this point to determine the best course of action, because from clinical parameters, from all the monitoring that we can get, the information you can get in this scenario is often not adequate. You would like to know the IVC volume and compressibility. You'd like to look at the myocardial function, if there is any pericardial collection and things like that. So that will guide you towards the best course of action. So options that we have, as Mir was just saying, the colloids could be an option. So ongoing capillary leak. In that situation, colloid can be an option. There are lots of new studies coming up.
And when you say colloid, can you be a bit more specific so that what colloid?
What colloid? There is no consensus. HES is most commonly used. But there are lots of concern, but there are lots of new, not big studies, but small studies are coming up, which is showing that albumin might be better. FFP may even be useful in repairing the glycocalyx, which is thought to be the main reason for ongoing capillary leak, which is often exacerbated by large volume of normal saline. And we are talking about using more balanced fluid, and there are some evidence definitely in adults that FFP and albumin might be better in repairing the glycocalyx and may reduce your ongoing capillary leak. But that's not into practice, it's just by the by yet. So colloid, we need to think about the volume of colloid we use. So not more than 10 mL per kg in a 24-hour period. And also at this stage, I will definitely think about inotropes, even if my cardiac function is normal. If there's little bit of inotropy may help, little bit of if the function is good, I may use a little bit of noradrenaline pressure agent as well. And
will you think about sepsis at this point?
Yes, of course.
And some and antibiotics. I hope the kid was not on antibiotics so far.
Yes. So at this stage, I will have a low threshold to start antibiotics, especially if the fever comes back, or I will check my inflammatory markers at this point, and if there is any concern, then I'll have a very low threshold to start antibiotics at this point of time.
Sure.
And myocarditis, I already mentioned, I'll be looking for myocarditis definitely at this stage.
For Shottambrata, I mean, the people often talk about abdominal compartment syndrome. Is there any role of when do you think about it, and when do you think about abdominal, and how to diagnose?
So abdominal compartment syndrome is a known complication of dengue. Huge abdominal distension is pressing the IVCs and decreasing the venous return to the heart and causing uncompensated cardiac dysfunctions that may lead to that is the feature of abdominal syndrome. That also impairs the renal functions also. We can suspect it in case of when the child is leaking fluid too much and there is a huge ascites and BP is not rising. There is a sign to suspect that there may be some the child is not responding to standard therapy. So that may be the reason that this huge ascites needs to be drained. And we can monitor also the pressure with a very simple device like putting a event catheter and attaching the transducer used for BP measurement that can be used to monitor the abdominal pressure. And if it is more than 20, then it is definitely the abdominal compartment syndrome, and it needs to be addressed first to correct the shock, and we can drain the fluid under, if it is a coagulopathy, under some APP or something, or if it's not there, then we can drain it.
Right. So say a good going abdomen, huge distension of abdomen with low blood pressure and low urine output, isn't it? And that's when you start thinking about it. Right. Let's talk about bleeding. I've got two cases. One is day 7. He has needed 120% maintenance fluid for about 24 hours. Little amount of, not more, not much. Now he's back to maintenance. His good urine output, his PCV is stable. His LFT is normal, and his platelets are 12,000. And then I've got another case who is also on day 7, but who needed 160% maintenance fluid, so needed much more fluids. His urine output is still just about borderline. He's on inotropes. He's acidotic. His lactate is high. His PCV is still high. So his perfusion has not been that good yet. His LFT is deranged. And his platelets are 22,000, 10,000 more than the first kid. So which patient do you think is more likely to bleed, and why it is so? This is for Mihir.
Yes, so very good distinction of the two cases. So as the scenarios you have mentioned here, so first patient, the relatively stable hemodynamics with looking good otherwise, but the platelet is low. But this patient, the platelet is going to rise very soon, and the patient will be okay. So the platelet, there may be and the second patient is hemodynamically still unstable, acidotic, and requiring inotrope, and most importantly, this LFT is deranged. So that is this patient case 2 is definitely going to be higher risk of the bleeding. The bleeding there are different causes of the bleeding in patient with dengue. So it's not only the thrombocytopenia. Thrombocytopenia is the minimum, contribute a very little, but it may be the dysfunctional platelet. It may be the coagulopathy and deranged liver function test, and the associated other features like uncorrected shock, acidosis, hypothermia. These are the lethal triad for bleeding, and this vicious cycle of deranged coagulation and bleeding in dengue patient. So that is why the other, your second question, the other parameters you also need now.
Yeah, answer that as well.
Yeah, so we need this liver function, complete liver function test. We need the coagulation profile, and not only the PT, INR or APTT, but also the fibrinogen level we have to be measured for this patient. That is very important factor. Sometimes the hypofibrinogenemia is the main cause of the bleeding. So these are the things I have to look for in this patient.
Yeah. And it's often the endothelium, isn't it? So the injury to the endothelium, acidosis, and all of that. So it's the important. It's not just the platelet count, but the overall profile of the patient, which is most important. Right. Now, a patient is bleeding from mouth, ET and NG. Platelets at 12,000. You have already given 9 units. What are your options? You have already given 9 units of RDP. So what can you do now? Is bleeding and his platelets are 12,000. This is for Prabhash.
Yeah, the patient is having platelet of 12,000 and patient is already bleeding, and we have already given 9 units of RDP. So my options is that I need to optimize the platelet counts definitely. When there's a bleeding, if you give platelets, they can help in the formation of the fibrin plug, and we need to give
given 9.
So we can give SDP. Definitely, you can consider SDP. And on the other thing is that other options are there. So you need to check that whether other causes of bleeding is there. As written here, the LFT is grossly deranged. The INR is 5.6 and APTT is 3.1. So you need to correct it. So at this moment of time, we need to consider about the factor replacement. So you have the options. You need to go vitamin K, definitely. And you need to correct the factors by giving either FFP or you can give cryo. So depending upon your fibrinogen level that you need to do.
Right. So do you do fibrinogen level all the time?
Yes.
Whenever you are having a patient whose platelets are low and
all the severe dengue, we are doing fibrinogen.
Sorry?
All the severe dengue, bleeding or non-bleeding, we are doing fibrinogen.
Right. Maybe so at ICH because you can do that. But not many places can do fibrinogen just like that, just from the drop of hat. Many places are still, their turnaround time is very long. They may take quite long time.
Another thing is that we have seen that severe hyperfibrinogemia is associated usually with adverse outcome. And the chances of cytokine storm is very high when the fibrinogen level is low.
That's true. I mean, that is something that we have learned over the years, that fibrinogen is very important. One point that I want to make is, oftentimes in many places you get thrombin time you get PT, APTT, and then TT. And we don't always look at it. But if it is hyperfibrinogenemia, then the TT will be prolonged, especially if your PT and APTT is normal, but your TT is prolonged, then that is a very definite marker for hyperfibrinogenemia. If you do not have, if you can be fantastic, but many places you cannot do it, then it can be a surrogate for your, of course, not as good because you will never get the level of fibrinogen, which is what you need, but it can be a surrogate for those places where you cannot measure fibrinogen. Right.
Your best option would be thromboelastogram TEG, isn't it? So if you have got access to TEG, that's tell you exactly where the deficiency is. But unfortunately, not many of us would have access to that. But if you have got somebody with severe bleeding, TEG is possibly the most useful investigation that you could do, that pinpoints the defect in the coagulation or clot stabilization process and can give you the exact answer that you need. But yes, most of us
but
don't
we are
have it,
struggling to get a fibrinogen right now. Okay, so another twist. A 5-year-old kid with secondary dengue on day 8 received up to 150% maintenance fluid, still needing it, also needing some inotropes. Right, so day 8, fever persisting. What are your thoughts? What are the differentials? What investigation would you send? This one should go to Shomenda. So day 8, fever persisting, still needing some inotropes.
Yep. So I would be concerned about this child. Dengue fever usually do not last beyond 5 to 7 days, and this child is also on lot of fluid, needing inotropes. So I need to think about complications of dengue. So I'll definitely, this is the time to think about secondary sepsis and HLH. These two would be my most likely complication that I would think about at this point of time. So investigation. So investigation, obviously, from sepsis point of view, I will like to look at the inflammatory markers and also cultures. If I've got lines from the lines as well, and peripheral blood culture and also urine culture, and all the HLH markers that we would look at normally. So ferritin,
So what are they?
yeah,
What are
ferritin,
the HLH
tri
markers?
ferritin, triglyceride, fibrinogen, and LDH is not in the criteria. I also tend to look at procalcitonin as well. It's not in the criteria, but I find it often quite helpful. So
How does
from
that
sorry, say it again.
How does that help? Procal.
Procal is often quite high, isn't it, in HLH? CRP is often non-contributory for diagnosis of HLH. I use H-score quite a lot.
Septic shock.
Sorry, say it again, Pravash.
There is also high in septic and septic shock.
Yeah, it can be. It can be. Yeah, of course. But I use H-score quite a lot these days. I don't know, many people don't like it, but problem with HLH criteria is there are at least two that you can't measure. So having a criteria, here comes the criteria. So soluble CD25 and bone marrow aspiration, we hardly ever do. And natural killer cell activity is also can be done, but that's a relatively complex procedure. So if you miss 3 out of 8 criteria and you need five criteria, it makes it a bit difficult syndromic conundrum to arrive at. So I use H-score a lot these days.
Sure. So essentially, so if your fever is persisting and your kid is unwell, and your numbers are down, your hemoglobin is down, your total count is down, your platelet is down, and that is when we start thinking about it. And essentially, we send those ferritin, triglycerides, fibrinogen, LDH has also become sort of customary to send, although it is not there in the formal criteria. But we often send them. And then if your ferritin is high and triglyceride high and fibrinogen low, that is when you think about it. And HLH, I think the awareness about HLH is really becoming sort of, it's coming up. Let's just, gloss over those.
Want to add one that we should not miss the other co-infections. Sometimes with dengue, we get the scrub typhus, with dengue, the enteric fever. So leptospirosis as well. So especially in this tropical countries and this monsoon season. So we are also sepsis, HLH, and secondary co-infections can be there associated with it.
Absolutely. I mean, three things should sort of, other sepsis. So if you're thinking HLH and will be starting steroid, almost everybody will start antibiotics by that time. You'll need to look at the heart and then, of course, think about the HLH. Now, so when to suspect, we have done all of that. So how do you treat how do you treat? So suppose you thought that it's HLH, you have sent a screen and it comes as positive. How will you approach? How will you treat it? It's a very very debatable questions. But let's get one by one. Mihir, how will you treat all of them?
Yes, we'll not treat if the patient the patient is fulfilling the HLH, and most of the patient, as Provas will now comment on that, the hyperferritinemia is there but not fulfilling the matching the criteria of HLH, because the primary HLH is meant for the congenital the HLH criteria is for primary HLH, not the infection associated HLH.
True.
So yes, so that's why we sometimes even there is hyperferritinemia we may miss. So H-score, as Shomenda has told, could be a better option. And the point of treatment or intervening in my clinical practice will be if the patient condition, day of illness, and when the patient presenting and the disease trajectory. If the patient is in the initial phase of dengue, in the critical phase, and there's only hyperferritinemia is there, we are still resuscitating the patient in that time, but the patient showing the improvement with the resuscitation, will wait and we'll do the further ferritin level within the 12 or 20, at least 24 hours, and see if the patients are associated with other organ function or deteriorating course, or the not hemodynamically unstable, even if after giving adequate amount of fluid resuscitation. And then we'll think with hyperferritinemia, we'll start the steroid or the along with IVIG in that point of time.
We're coming to that. Come to the therapy. So the point that Mihir has made is,
just want to
yeah,
mention.
Prabhash, I know you have raised your hand. You will get a chance. Let me just what Mihir has just said is that just because your HLH screen is positive does not mean you want therapy. Does not mean you need treatment for HLH specific treatment. You need, but possibly once if the patient is also deteriorating, especially if the patient is getting new organ dysfunction or organ dysfunctions are getting worse, that is when you should consider HLH specific therapy. Yeah, Prabhash, you have raised your hand.
Actually, in dengue, we are what's in a name basically? Maybe HLH, maybe cytokine storm, maybe cytokine release syndrome. In dengue, usually we see two types of these types of incidents. Now, currently, fortunately or unfortunately, we are dealing two such type of case in ICH-PICU. One type of case is that a kid presenting with a typical shock, he's afebrile, severe shock, refractory shock. Initial resuscitation done, all the initial blood report is severely bad. He is bleeding, the liver has been damaged, kidney has been damaged, not passing urine, lungs is flooded, intubated, ventilated, and he was sending a ferritin is coming at 70,000, 80,000, more than 1 lakh, needing inotrope. It's a MODS, and he is afebrile for the last 12 hours or 14 hours. This is a one type of presentation. At presentation, you have sent a ferritin, it is 70,000, 1 lakh, 2 lakh, 3 lakhs, like that. Another presentation is that the fever was there for 5 days, 6 days, 7 days. Then afebrile for, you say, 12 hours or 24 hours. Again, the fever reappearing. Or the fever is being continued. The thrombocytopenia is being continued. The capillary leak, the bit capillary leak is continuing. The ascites is there. Platelet fails to remove. But new onset fever spikes is there. New onset hepatosplenomegaly. Ferritin, you say around 15,000, 20,000. Hemoglobin a bit on the lower side. But patient is not that amount of multiple organ dysfunction, and patient is not afebrile. Patient is still febrile. This is another type. The second type is typically of what we call HLH. The new onset fever or failure to resolution of fever, new onset hepatosplenomegaly, persistent a mild capillary leak, not as sick as number 1 patients. In number 2 patient is easy, that if like the case you have shown here, that 8 days still the patient is febrile. If you are excluding topical infection, you are excluding co-infection, if you are excluding your hospital-acquired infections, then still the cytopenias is persisting, ferritin inside, diagnosis only is there is HLH. It's simple, you can give steroids, you can give IVIG. But in the first case, when the patient is afebrile for the 12 hours, presenting with a 70,000 ferritin, is profusely bleeding, fibromyalgia is not measurable, multiple organ dysfunction, whether to treat, according to me, that first we'll try resuscitate for the patient for 12 hours, then we send the ferritin. If it's rising, we'll treat. If it's coming down, we'll not to treat. The question is that in first type of cases, when to treat, how many days to treat. The confusion is among the first type of case that told that I do resuscitation and see after 12 hours of ferritin whether the patient is improving or not. But the second case, we don't have any doubt. That's the confusion among the intensivists, I feel.
Right. So basically what Prabhash was saying, again, I will again stick to that if you do not have organ failure, it is absolutely okay to wait and watch and maybe follow up your ferritin. And if your ferritin is coming down, don't do anything. If it is not coming down and you have decided to treat, the second category that Prabhash has said, bleeding, when bleeding comes and then the organ dysfunction progress very rapidly, those are the patients where we don't really know what to do. I do not really want to spend a lot of time because we don't have any consensus and we don't really know what to do. But let's talk about that bit where we have a little bit of consensus. For the general audience. So if you decide you want to treat, how will you treat? Who will answer it? Shomenda? If you have decided to treat HLH, and what will be your first two options?
Yes, my first choice would be steroid, and I prefer dexamethasone. Some people use methylprednisolone as well. I mean, I don't have any problem with that, but I am more used to using dexamethasone. That's personal preference, you can say. IVIG, I use sometimes, but I think if it's in my mind.
I'll just ask you once more here. Suppose that you are using steroid, and you will continue steroid for how long? How do you decide on that? Your duration of steroid.
Duration of treatment, I decide on the response of the patient. So if the patient gets quicker very quickly, I don't always stick to 2 weeks of steroid like that. So some patient actually got one patient just now. We started steroid yesterday, and the fever settled after about 8-12 hours, and the child looking much better today. So I'm pretty sure I'm not going to give the steroid for 2 weeks. I don't think it makes any sense to give steroid for 2 weeks.
HLH protocol, it says for 8 weeks. So you will definitely not give for 8 weeks.
I will definitely not give for 8 weeks. If I think somebody needs that prolonged therapy for HLH, then I probably will get a rheumatologist involved and have some opinion from them. If they're responding to steroid, I just follow them clinically, and then I may have a much shorter course. I may just choose to give much shorter course.
Yes, I think the short course of steroid, this 5 to 6 days maximum, because if the patient is not responding with the steroid starting within the 48 hours, then I think it will not work. So continuing without the patient is absolutely no response after steroid, then continuing with it a bit, it may be counterproductive. So that maybe the sepsis and the other things may rise. And if there is inflammatory marker is going down, patient is improving, I think short course 5 to 6 days maximum, then rapidly tapering down.
That's right.
IVIG, what is the, when do you use IVIG? What are its positives and what are its negative as opposed to, say, steroid?
So when that kind of patient that presenting initially with high organ involvement, bleeding, and we really can't exclude sepsis in that patient. We don't have time for wait to come out the blood culture and to be negative and then start steroid. So in that group of patient, we can try IVIG, and the child is very bad and needs some urgent therapy, and we are not able to exclude sepsis. So that is where we can start. And another group of patients that have prominent myocarditis feature with HLH. In that group of patients, we sometimes start with IVIG. Cost is also a very important factor when we consider IVIG, especially in case of big children. And efficacy, especially if we compare with steroid, I think, in my opinion, it is not that very efficient. Sometimes we have to start steroid after that using of IVIG. And volume, if we are considering a myocarditis patient, we usually don't want to overload the child with volume, and we usually use small volume every day, like 5 days protocol for in that case.
Right. So
Ognita, we have already 45 minutes, so we have to.
No. I've just completed 40 minutes. My timer has just gone up, and I'm going to stop here. I'm not really going into Anakin Rand, because I don't think that's it's not really appropriate to stop here. So just to summarize IVIG. So possibly one is it actually treats our insecurity more than the patient possibly, because often when you are not sure whether the patient has got sepsis or not, and then to give them such a patient something like methylprednisolone or dexamethasone, we basically chicken out. We worry. And then we think that IVIG will be safer. But if you look into the evidence, possibly evidence is much better for steroid rather than IVIG. It will of course cost a lot more, especially in bigger case. In government sector, it may be a different issue because you may get it free. And often it involves giving quite a lot of volume that can be an issue. So sometimes we may have to give it in sort of, over 5 days. So steroid and IVIG, on this there is no doubt. And beyond that, I think it's a minefield, and let's not go there. So we end the discussion here. Thank you.
Thank you.
Thank you.
Top share.
Stop share. New share is stop. Stop video. Stop share. Oh, hang on.
Yes.
Stop. Oh, shares. Oh, yes, stop this.
Yes, Sapanda.
Yes, actually, I was searching for the question, but Ogni has moderated the session so well, everybody understood everything. And with the eminent panelists also. So I think they have got tired for 3 hours. Okay, so it was an excellent
participants is also
experience.
almost halved.
Yeah, it has reduced to half. It has reduced almost to half.
That's about right. Yes.
And thank you, Mihir, and all the participants and panelists for joining this session on the dengue. And I am also thankful to Professor Kalpana Datta, our president, and the government dignitaries from the Shastro Bhavan. So they have joined and they have also participated and they have shown interest how to curtail the dengue. So if you all try with our knowledge that we have imbibed today, possibly we can do some better to our ailing children. So thank you everybody once again. So it's over to Professor Kalpana Datta, the president of WEP, to conclude the session.
Atunu is
thank
there,
you.
Dr. Champok Das is there.
Yeah, I request Dr.
Champok
Atunu and Dr. Champok is there. Please say a few words. Dr.
Champok
Atunu
is enjoying
and
in
Dr.
No, it's a background screen made by me. I'm at home. No problem. And I enjoyed a lot and learning from the juniors also. Thank you. Excellent session.
Atunu.
And Dr. Atunu is there. Atunu. We বললে নাকি? He's not responding.
Atunu, conclude the session.
Dr. Atunu, তুমি unmute করো.
Yeah. So revisit was almost many things we got to know many things new. Just like when we were engaged with COVID, we only saw COVID in everything. I hope that we don't have to see dengue in everything. And please, I think in the future, I would request Mihir and his team to look into scrub typhus and other diseases also. Otherwise, with all the division going on, we'll be forgetting all other infections. Thank you.
Oh yeah, thank you, Dr. Atunu. You have rightly mentioned we should look at the other diseases which are prevalent in this time also. And I must thank Dr. Mihir because in a very short time, once I went to attend some meeting in Sastavan, I think 4-5 days back, and DHS requested me to have another dengue webinar as we did in July. So I was at a
We did in August. 12th August.
Exactly. That is monsoon melody. So I was at a loss. How can I manage it in such a short time? But his total credit goes to Mihir. He arranged such a nicely, and all are present, and all the dignitaries also took part in such an enthusiastic way. So I'm really obliged for that. So the WAP and all the panelists, the faculties, and the audience who made this webinar very interactive. Thank you all. And again, we'll have another webinars to enrich us about other tropical diseases or causing different causes of fever having in this monsoons or after falls or during falls.
Mihir and Ogni, I think we can have a session in the state conference also.
Yes, we will. Okay. So
please arrange another webinar. Just a point. Please arrange another webinar involving the influenza also. We are facing a lot of influenza also, we need to
Yes,
discuss
yes,
about
causes of
it.
fever.
Yeah,
How
cause
to
the fever influenza is creating havoc in Murshidabad.
There was
However,
also
Hare
a
Krishna.
request for drowning, and me thought that drowning and burn, these are two things that we hardly talk about. We may do that also, but I think we'll possibly have to do it post puja. I mean,
I
Yes, there
really
is
feel
a
happy that
recent report of the drowning is highest in South Chobbish Pargona among the world, all over the world. So
yes,
report from the
yes,
WHO.
Sundarban
There
and
is
all.
also death, yes. So a lot of death also.
Ogni is
This is
preparing
also
a module.
so really
Sorry?
happy to see you all are interested in academic discussions. So we'll have more and more in future to enrich us and give the better health to our kids in our state.
Sir is there,
So-
Professor Sukanta Chatterjee sir, and also Professor Sumita Basu. Sumita Basu, sir.
Dr. Shukanta sir, if you want to say something, is he still
It's,
there?
I am really
Left.
amazed. I am really amazed that it started from administration, then it went into the level of ICO. So it's everything of dengue. So that's very nice. But of course, 3-hour session, that is a little lengthy, but it covered everything. Thank you very much, all the faculties.
Thank you. Good night.
Thank you all.
Good night.
Good night.
Good
Good
night.
night.
Good night.